the place that you hosted was badly.
Yeah, that's what.
So how is Hari? Hari is doing well. Hari is my...
Dear participants, on behalf of the Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, it is my proud privilege to welcome you all to the Hand Fracture Fixation Workshop. We are honored to host this event with the participation of eminent experts in the field of hand surgery. I would now like to invite Dr. Sanjay Kumar Giri sir, our organizing chairman, to say a few words.
Good morning, everyone. Welcome to the Department of Burns and Plastic Surgery, AIIMS Bhubaneswar. So I would say a few words. This is a hands-on workshop on the hand fracture fixation. I think we 35 people have registered, all are plastic surgeons, and what we saw during initial time, we are able to manage the soft tissues, but we are not able to know how to do this bones fixation. Although we know only K-wire fixation, but today with us two experts, and along with our local faculties, two experts, Ravi Bharadwaj sir and Tahir sir from AIIMS Bhubaneswar, and sir is from Calcutta consultant, I think, and Vibhuti sir, Subrat sir will also join. They are all our local faculties. So I think by 2 days, 1 day this hands-on workshop, you will able to know how to do, what not to do. And there is a didactic type of lectures, nothing like whatever you want, whatever you have the problems, you can directly discuss. That is the main theme of our this workshop, so that we can have better results at the end of the day. And I am also thankful to Tahir sir and Ravi sir, who has made this program fully 1 day, and so that we can have good results at the end of this one. With this, I hope this will help you, and we will start immediately with this one. And before starting, I just want to say a few words. We have one of our colleague, Dr. Debidatta Sahu. He is very dynamic plastic surgeon. Just passed away just 3 days back. We have just covered 11th day of his death here. So I would say that for 1 minute we would have a silence, then we will start the program. Thank you. Thank you. And about the course, before starting the first lecture of Vibhuti sir, I can ask Ravi sir to tell brief about the course so that we can start it.
Good morning, everyone. Welcome to this hand fracture fixation workshop. So, when Dr. Sanjay asked me to sort of come for this workshop along with Dr. Tahir, we are very honored and thankful for the opportunity. And we decided to put together a course with content which would be very relevant to your day-to-day practice. We don't need to teach you how to do soft tissue management, you know that better than us. But most of the time, basically, we find that, there is a very artificial divide in hand surgery between orthopedic hand and plastic hand. But hand is hand. There is no orthopedic or plastic. All orthopedic surgeons should know enough about soft tissue coverage and handling soft tissue. Similarly, plastic surgeons should also be conversant with the basic principles of fixation of fractures. So that is why it's a Venn diagram with a lot of overlap in between. So courses like this will help to sort of, refine your skills so that you feel comfortable handling bone. Conversely, I think Sanjay will help us organize some similar courses for flap coverage for our orthopedic fraternities, for us to learn more about soft tissue. And it's a mutual two-way progress. So it's a one-day course. We have tried to keep the content as relevant as possible. So first we will have some didactic lectures followed by sawbone models. So during the sawbone models, you will be handling sharps. So be very careful with the drill and KY. We don't want any injuries on Saturday when going to your emergency. So be careful with the sharps. I think it will be an interesting course. We'll keep it very interactive. So feel free to ask any questions. It's a very relaxed environment. It's not a formal teaching environment. Okay. So feel free to ask any questions. No question is silly. That's how we learn. We learn a lot when we come to these courses because a lot of our concepts get cleared when you ask us questions. So let us keep it a very informal two-way discussion. And without wasting much time, let's proceed. I think it will be a very fun-filled day of learning. That's the whole objective. Okay. Thank you very much.
Thank you, Dr. Sanjay. Thank you, Dr. Ravi. It's a wonderful opportunity to be here, actually, and to interact with the new budding hand surgeons. It's a really nice thing because once we go to conferences and all, and most of the time, those who have come for workshop, they have reached the stage where it's difficult to train them. And you're in a phase where we think you will know basics correctly, and you can use that technique perfectly the way it has been described in the literature. So it's my pleasure to be here, and it will be my pleasure again to interact with you with full enthusiasm. Actually, most of the time, residents are not that much, they are apprehensive. Don't worry, okay? Forget about everything, clear your all doubts. Okay. Thank you.
Thank you, sir. To begin today's academic extravaganza, we have the first talk on Principles of Treating Hand Fractures by Dr. Bibhuti Bhushak Nayak sir, Professor and Head of Department Plastic Surgery, SCB Medical College, Cuttack. With over 22 years of dedicated government service, he is a proud pioneer in reconstructive surgery, having conducted over 9,000 free flaps and over 1,000 replantations, including a double hand replantation. Sir, I would request you to grace the dais and enlighten us today.
A very good morning to all of you. At the outset, I must thank Dr. Giri to have invited me for this. And I must congratulate him and his team for organizing this unique hands-on workshop on hand fractures, which is not familiar to the plastic surgeons. And as Dr. Ravi pointed out, the best way forward is when both orthopedics and plastic surgeon do the hand surgery together. But it's not possible most of the time. So we have to be conversant with hand fractures and the orthopedicians with the soft tissue management. Amongst the faculties, I am the odd man out because I don't have the orthopedic background. I am MS General Surgery. All other faculties are orthopedicians. And paradoxically, I'll be speaking on hand fractures, which is not my forte. So principles of managing hand fractures. Slide is not changing, Giri. Slide not changing. It's not changing. But this way, so the hand is a complex anatomical and functional unit. So the precise management of the fracture is vital. The goal is to restore anatomy, stability, tendon gliding, and early motion. There are 27 bones, the carpals, metacarpals, and phalanges. It has a rich vascular envelope. The tendon systems, both flexure and extensor apparatus, are the gliding apparatus. And the key stabilizers are the collateral ligaments. So these are the various possible fractures in the hand. See here, I'll show you the various fractures. So the classification overview, based on the site, it can be phalangeal, metacarpal, or carpal. Based on the pattern, transverse, oblique, spiral, comminuted, or intra-articular. And based on stability, it can be a stable or unstable fracture, open or closed fracture, simple or compound fracture. The general principles is to preserve the soft tissue, gentle handling of the soft tissue, and minimal dissection. Achieve anatomical reduction of the joint when involved. Maintain stability for early motion. And preventing stiffness is the key, because we have to start early mobilization to prevent the stiffness and avoid hardware permanence and tendon irritation. So when we see a patient, obviously the deformity and swelling lead us to the site of the fracture. So we inspect for any rotational or alignment problems. But more importantly, at this stage, we must rule out any neurovascular injuries. So if we miss a nerve injury at this point or a tendon injury at this point, it can be difficult later on to manage. And even I have seen cases where the vascular injury has been missed and the patient has landed up with gangrene of fingers. So we have to be very, very careful when we first examine the patient. So the tendon injury will not be missed if you do a good functional assessment. Radiological radiographs will guide us to not only see the fracture but classify the fractures as well. Epilateral and oblique views or two lateral views are essential. So in complex intra-articular fractures, one should do a CT scan to assess them better. So once the diagnosis is made, we have to reduce the fracture and maintain this reduction and then rehabilitate the fracture, the hand. The reduction can be done by manipulating under anesthesia, by giving traction or open reduction or closed reduction and fixation. So the principles of managing the fractures can be by external splinting or internal fixation or external fixation. These are the various modalities by which we can treat. The indications for non-surgical management is when it is a stable and undisplaced fracture. So the body tapping or functional splints in functional position or the intrinsic position will solve the purpose. Immobilization is usually for 3 weeks based on the fracture, followed by physiotherapy. So the advantage of non-surgical management is there is minimal soft tissue disturbance. So the advantage of non-surgical management, as you can see, 90% of hand fractures are appropriately treated without surgery with simple reduction techniques, appropriate splinting, and early protected mobilization. And the complication rates of operative treatment can be as high as 36% in metacarpal fractures and 50% in phalangeal fractures. So when we decide to operate a fracture, it has to be done judiciously. So coming to splints, these are devices to maintain reduced fractures in desirable position. The ideal position is one that best resists the fracture displacement and soft tissue shortening with minimal stiffness. The splinting, it immobilizes the fracture and promotes secondary healing. Because the fracture is splinted, it gives pain relief, reduces further neurovascular damage, and even reduces the chance of a possible open fracture. The splints, external splints are cheap, versatile, strong, and radiolucent. It can be also given by traction, splints, or brace. So this is a nail traction. Simple phalangeal fractures can be treated by nail traction. Mostly the fractures of the proximal phalanges, base of the proximal phalanges. Splints It can be slab or cast. The brace prevents joint stiffness while still permitting fracture splintage and loading. It's not very rigid, usually applied only when the fracture is beginning to unite. These are the various ways of fixing a fracture. This is the external fixator, rest all are internal fixations. The elastic nail plates, screws and K-wires and the plate and screws. So operative indications. So we operate on the fracture when it's the unstable or displaced. There is rotational or angular deformity. There is intra-articular displacement, open fractures, or multiple metacarpal or phalangeal fractures. The approach can be dorsal or volar depending on the fracture site. Gentle soft tissue handling is very, very important because here you have the small digital vessels and nerves. One has to operate with magnification and with fine instrumentation, maintain or minimize the periosteal damage, and the stable fixation should be done with minimal implant bulk. The options are K-wires, mini screws and plates, intramedullary fixation, or external fixator. Absolute indication for internal fixation is when you are unable to obtain an adequate and stable fixation. Displaced intra-articular fractures or certain type of displaced epiphyseal fractures or major avulsion injuries. Relative indications are delayed unions when there are multiple fractures to assist in care and general management, or pathological fractures, or to reduce morbidity due to prolonged immobilization. In elderly, if you do a internal fixation, the patient can be mobilized faster, otherwise they are prone to develop stiffness very fast. And the complications are infection and non-union. Non-union is usually because of excessive stripping of soft tissues or unnecessary damage to the blood vessel, or when we do a rigid fixation and we leave a little gap between the fragments, that can lead to non-union. K-wire is a coaptive fixation. The screw fixation that we do are stable fixation, but if you want a rigid fixation, it's the plate and screws which give you rigid fixation. Indications for K-wire fixation: fractures in epi and metaphyseal areas, phalanges and metacarpals, small bony fragments like the ulnar and styloid processes, radial styloid processes, or fragment reposition in multi-fragmentary fractures in addition to stable fractures like Bennett or Rolando. K-wires, they do not give you sufficient stability because they are axially unstable. So to neutralize that, one can go for a cross K-wire or double K-wire fixation. The advantages of K-wire: it's cheap, universally available, can be inserted with a drill, and easy to remove. Don't require any anesthesia. Screws, lag screws, they compress both sides of the fracture together. This is the best form of compression, but the disadvantage is poor shear, bending, and rotational force resistance. They should be inserted perpendicular to the fracture. Otherwise, as you can see in this picture, it can lead to displacement. You can also use intramedullary cannulated compression screws for the shaft fractures or the neck fractures. Plate and screws. There should be low profile plates to minimize soft tissue irritation, because the soft tissue envelope is not very bulky in the hand. Maintain the precise contouring to the bone is important. Maintain periosteal blood supply, otherwise there will be problem with bone union. And use lag technique for compression where appropriate. The advantage is rigid fixation enables early motion. So this is critical for optimal hand function. External fixators are usually used for temporary fixation, and they are used if the patient is not fit for surgery, but the definitive procedure should be done when the patient is fit or improves. In excessive soft tissue damage, once the soft tissue is healed and there is no pin tract infection, one can remove the fixator and go in for a proper internal fixation. But external fixation also can be used as a definitive modality of treatment. Soft tissue healing is not satisfactory after 4 to 6 weeks, and there is no pin tract infection. The fixator can be left as such until the fracture has healed. In non-compliant patients, it can be the first and the final modality of treatment. In the children, if you have used at the first sitting, then it can be left alone because the fractures heal early. So it can be used as a final modality of treatment in children. So external fixator can also be used as a joint spanning frame, especially for the intra and perireticular fractures or ligamentous injury. This is most commonly used in the fingers and wrist. And one can also continue physiotherapy while this joint spanning frame is in place. So the metacarpal leg fractures, one can use K-wires or plate or even elastic nail. Sharp fractures, avoid rotational malalignment. So rotational deformity is a big problem that has to be taken care of. Phalangeal fractures, it can be intramedullary K-wire or screws. Intra-articular fracture, one has to do a ORIF with lax screws or mini plates. Carpal fractures, especially the scaphoid and hook-up hamate, need special attention. Rehabilitation is as important as the surgery, so early controlled motion is the cornerstone of a good outcome. Sprinting in functional position, and one has to prevent stiffness, edema, and contractures. The complications usually are malunion, rotational or angular. Deformities may occur. Stiffness is the most common complication. That is why we are stressing so much on early mobilization. Non-union is rare because the hand has very good vascularity. So if the surgical technique is not good, then one can land up with non-union. Infections and tendon adhesions are additional problems, and again, the tendon adhesions can be taken care of by early mobilization. The CRPS and hardware irritation are other additional complications. In summary, hand fractures require precise diagnosis and individualized management. Aim is stable fixation with early motion, preserve soft tissue and tendon function. It has to be a team approach, especially the surgeon and the hand therapist must come together to give a good result. And the good result is good reduction with early mobilization or early rehabilitation. So precision, stability, and motion, that is the core of hand function. Thank you. This is just a small video of a double hand reimplantation. 1 minute video. So this takes care of the fracture, soft tissue, and everything. So this is a mid-palm bilateral hand amputation. So this was just there. So in reimplantations, you have to fix the fracture, you have to do all the soft tissue now. So this tests the full gamut of your training in hand surgery. So fractures, only fracture takes your orthopedic skill. The soft tissue injury tests your plastic surgery skill. Reimplantation tests all your skills. Thank you.
Thank you, sir. Next, we have a talk on X-rays and hand injury by Dr. Tara Prasad Tripathi, sir, Assistant Professor in the Department of Radiology, AIIMS Bhubaneswar. Kindly grace the podium, sir.
Thank you for the opportunity. So we'll be covering in the next 15 minutes. We'll be covering some basic hand radiographs, how to interpret those radiographs, and basically how not to miss some common injuries. So this is the basic bony anatomy of the hand. Fracture of the scaphoid in this view, as well as besides that the pisiform is proximally 1 to 4 millimeter proximally displaced when the ulnar deviation view is taken. You can see the pisiform is overlapping over the triquetrum in a routine PA view, whereas in a PA ulnar view the pisiform can migrates proximally and is easily seen, so the overlapping is avoided. So the advantage of PA ulnar view is better visualization of scaphoid and pisiform. So the fingers also can be seen in various views like PA, oblique and lateral view. Thumb similarly can be viewed in AP and lateral. The basic purpose of taking multiple views is to pick up fractures and injuries which are not picked up in one view. So coming to scaphoid fracture. So this is the most common carpal form that fractures, and the mechanism of injury is the fall on outstretched hand. Most common fracture is the west of scaphoid fracture. So the radiological features of a scaphoid fracture is this fracture line that is seen predominantly in the west of the scaphoid, which is commonly fractured. So this scaphoid fracture may be associated with a scapholunate ligament disruption as well. So you can see this scaphoid fracture commonly presents with this occult fracture. Means here you can see in this scan that was done immediately after the injury, this fracture line is not so well seen. However, if you follow it up and after a week, this scan was done where you can see this body margins have resolved and the fracture line is better seen. So in a patient who has clinically you are suspecting of having fracture but you are not able to identify, follow it up at a 7 to 10 days follow-up X-ray where the fracture line may be better seen. So complications of scaphoid fracture are AVN, non-union, carpal instability and arthritis. So this shows how once the fracture line migrates proximally, the incidence of AVN increases in scaphoid because the nutrient artery comes from the proximal part. So in this case, which is a follow-up case of scaphoid fracture, you can see the fracture line in the west of scaphoid, and there is non-union as well as AVN of the proximal part of the proximal pole of the scaphoid. Whereas in the second case, you are able to see the fracture line slightly distal to this case. So there is no AVN, however there is non-union of scaphoid. So coming to carpal instability, so once there is ligamentous injury or bony injury, there will be carpal instability, which can be scapholunate dissociation or a dorsal intercalated segmental instability, or a lesser common type, that is ventral intercalated segmental instability. So basically this results from bony injuries and ligamentous injuries of the carpal bones. So coming to the second most common fracture, that is tricuterral fracture, which is classically described as the whooping duck sign. So as we have already seen the lateral radiograph, which consists of this, we want to identify this radius, this piece of bone is the lunate, so this is the radiolunate articulation, and this V-shaped bone is the capitate. So radius, lunate and capitate should be in one line. So it has been described as the capitate being the body of the duck, and this lunate as the feet of the duck, and this green annotated is the tricuteral, the piece of bone that has avulsed because of the radiocarpal ligament, which has avulsed this piece of bone because of tricuteral fracture. This is described as two. So this is classically described as the whooping duck sign, which indicates tricuterral fracture. So carpal bones undergo dislocation once there is a fracture or there is ligamentous instability. So before going to the dislocations, you have to identify these three lines in a PA radiograph. That is the proximal line formed by the convexity of scaphoid, lunate and tricuterus. The second line formed by the distal aspect of this piece of bones, and the third line that is formed by the capitate and hamate. So these three lines should be parallel to each other, and this arc should be maintained. So any disruption of this arc indicates there is underlying fracture or there is any ligamentous instability. There can be anatomical variants, but for simplicity you should consider whenever there is disruption of this arch, there is underlying ligamentous or bony injury. So coming to lunate dislocation, there are four dislocations that we will cover now. First one is the lunate dislocation. So what is lunate dislocation? So basically, as we have already seen, the three bones that you should be able to identify on a lateral radiograph, that is the radius, the lunate, and this V bone, that is capitate. So radius, lunate and capitate should be in one line. So whenever the lunate dislocates, that means there is disruption of this radiolunate articulation, that is lunate dislocation. So in this lateral radiograph, you can see the radiolunate articulation is disrupted and lunate has dislocated. So this is lunate dislocation. The point we have to make difference is perilunate dislocation. So before coming to this perilunate dislocation, just we will see two radiographs. One showing this lunate dislocation, which is classically described as filled teacup, and on the PA radiograph, you can see this arch that we saw just recently. The middle arch and the distal arch has been disrupted, and this there is overlapping of these three bones. This is classically described as the triangle sign or the piece of pie sign. So if the arches are disrupted, that means there is some fracture dislocation underlying. So coming to scaphoid dislocation, once scaphoid is dislocated, it will migrate laterally, and this interval between scaphoid and lunate will increase. Measurement wise, it is called more than 3 millimeter as scaphoid dislocation, as well as the lower pole of the scaphoid becomes end on in appearance, and there is signatory in appearance. So these two findings, that is increase in the scapholunate interval and end on appearance of the scaphoid, suggests scaphoid dislocation. So these are the 4 dislocations I was talking about. We covered the the lunate dislocation and the scapholunate dissociation. The next 2 dislocations are perilunate dislocation and mid-carpal dislocation. In perilunate dislocation, so in lunate dislocation, what we saw is the lunate has been dislocated. That means the radial lunate articulation has been dislocated. Whereas in perilunate, the radial lunate articulation is maintained. The radial lunate articulation is maintained, however the carpal bones around the lunate has been dislocated. That means the radial lunate line is maintained, whereas this capitate is away from the line of the radial capitate line. Okay, so this is lunate dislocation. So for comparison purpose, this is the normal radiograph. In the lateral radiograph, this is radial bone, this is lunate, and this is capitate. So once the radial lunate line is disrupted, that means this is lunate dislocation. Radial lunate is maintained and bones around the lunate dislocated, that means this is perilunate dislocation. So this is lunate, this is perilunate dislocation. So there is another additional entity, that is trans-scaphoid perilunate dislocation. This means there is an associated scaphoid fracture. Rest everything is perilunate dislocation. The fourth type of dislocation that we described is mid-carpal dislocation. So this is the normal radiograph, that is radius, lunate and capitate are in line. However, if none of them maintains the line, that is lunate is also dislocated, capitate is also dislocated from this radial line, that means this is mid-carpal dislocation. So there are three major dislocations that we described. One is this, what is this first type of dislocation, where you can identify what is this type of dislocation, where the lunate is away, that is the radial lunate integrity is disrupted. This is lunate dislocation. The second one, radial lunate is maintained and capitate is dislocated, perilunate. And the third, where everything is not in line, is mid-carpal dislocation. So coming to some other fractures that of involving the metacarpal bone, that is simple fracture, however involved in interarticular, two-part fracture. This is Bennett's fracture. This is the base of metacarpal. If there is 3-part fracture and it is also interarticular, it is known as Rolando's fracture. There can be fracture of the neck of the 5th metacarpal, classically described as boxer's fracture. There can be fracture of the shaft of the metacarpals. There can be phalangeal fractures. The most common phalange that is fractured is the middle finger. So there are certain named fractures that you should know. These are also common fractures. First is where the ball hits the tip of the finger, where there is hyperflexion and there is injury to the common extensor tendon. That means the common extensor tendon is fixed and it removes a piece of bone from the distal phalanx, classically described as the mallet or baseball finger. Where you can see this is the chip of avulsed piece of bone which is connected to the common extensor tendon. The second one is the hyperflexion, which can occur while holding the jersey of a moving player, which occurs in rugby matches, known as jersey finger, where the injury is in the flexor part of the bones of the distal phalanx. This part is attached to the flexor digitorum profundus, and the most commonly injured bone is the 4th digit. The gamekeeper's thumb or skier's thumb is the injury of the thumb of the middle phalanx, and this is where the ulnar collateral ligament attaches. So the ulnar collateral ligament is a fixed structure. So there is avulsion of this part of the bone. So whenever there is identification of gamekeeper's thumb or skier's thumb, you should always evaluate the patient with a high resolution ultrasound or MRI to identify this Steiner's lesion. Basically, Steiner's lesion is the interposition of this aperture pollicis longus tendon aponeurosis in between the avulsed ulnar collateral ligament, which is identifiable on an MRI or an ultrasound. So coming to the end, there can be interphalangeal joint dislocations also and double interphalangeal joint dislocations also. So these are the common fracture dislocations that we identify on a hand X-ray, and this should not be missed. Thank you.
your presentation is not complete. You cannot ask questions. That means you have not actually initiated us to reciprocate with your presentation. Anyway, you have told about the upward fracture in the waist. So after 1 week, you are telling there will be a marginalization or there will be demarcation of the fracture line.
Yes, sir.
So then how it will determine the decision for the surgery?
Actually, sir, that is to so that, that normally in all fractures this happens. But to identify a fracture early, we have to take additional views. Like that view was only PA radiograph. If you would have taken an ulnar deviation, the fracture would be better seen, and we can then manage the patient, manage the case.
So because earlier surgery, I think sir can elaborate on that.
Yeah, actually, first fracture, question is, sir, whether to fix it or not. So it depends upon whether it's displaced or undisplaced. If it is undisplaced, then there are two schools of thoughts where you can, if a high demand patient, you can fix percutaneously for undisplaced fracture. Otherwise, 95% of the time, it's the cast. Now the controversy comes whether with thumb, without thumb, we will discuss in the lecture. And if it's a displaced fracture or unstable fracture, that means if there's a combination or displacement of more than 1 mm, then you have to fix it. There's no other way. Just one question from the delegates to awake you actually. I ask this question to all my residents, and most of the people here are residents actually. So the question is, 18-year-old boy comes to you with injury to finger, with pain and swelling in the middle of the finger. Which X-ray will you advise? Anybody? So advise X-ray of finger, PA and lateral view. Don't advise X-ray of hand, PA and oblique view. Okay?
Thank you, sir. We move on to the next talk on conservative treatment of hand fractures. Dr. Subrat Jena is a revered and dedicated plastic surgeon with unwavering commitment to his community. He has created his own sanctuary of healing, the Ashwini Hospital, where countless patients found solace in care. His has been a lifelong commitment to the well-being of others, which continues to inspire the next generation. Sir, I'd like to invite you to deliver the next talk.
Very good morning to all of you. Am I audible? Yes. Okay. So, to introduce myself, I'm an orthoplastic surgeon. So I did my MS in orthopedics in the year 1980 to 82, and then went on to do my plastic surgery training. So I wish to be introduced as a hand surgeon. In fact, from the time I passed out till today, 75% of my practice has been hand surgery. And I would like to declare that I am a conservative surgeon, having gone through and seen complications of different methods of treatment. In the last 45 years of my practice, I have devised something which is safe, good for my patient, and on the top of it, least expensive. I desire to speak on K-ware, which is being now covered by my colleague, because in the management of fractures, as Professor Naik has already told, majority of the fractures can be treated conservatively. You said 90%? I would not agree more. That all these fractures can be treated in a hybrid mode, if not purely conservative. That is, close reduction under an image control and immobilization with very fine 0.8 mm, one or multiple K-bars. That would be my take for most of the fractures of the hand. The important thing in managing a fracture of the hand is not the fixation, but the post-op care. As you all know, hand has so many small bones, muscle, tendons, ligaments. They tend to become stiff very quickly. Therefore, a 3 weeks of immobilization can play havoc. And therefore, one should be acutely conscious that you are working with a hand therapist who understands that the hands need to be mobilized from the word go. You cannot wait for 3 weeks for mobilizing the hand. So supposing it is also with the soft tissue injuries which need immobilization, like supposing there is a fracture of collateral ligament, torn collateral ligament, or injury to the flexor tendons or extension tendons, you would like to mobilize while keeping this injured tendon or the ligament at rest. So I would not hesitate to say 50% of the work of a hand surgeon is that of the physiotherapist or the occupational therapist. And this has been well dealt by by Professor Naik. I will just briefly touch upon certain salient points, like what are the fractures where you can opt for conservative therapy, and what are the fractures that you should not try conservative therapy. But when I say not conservative therapy is not an open reduction and internal fixation always. You must always keep in mind that conservative and internal fixation has a gray area which I would call best managed by the hybrid method of treatment. But reduction must be obtained. If you are planning close reduction and no internal fixation or a limited internal fixation, the reduction has to be achieved under an image intensifier. If you do not have an image intensifier, probably you will dwell more on opening up the fracture to see what has happened. But with the advent of a CT scan which can give you a picture of what are you going to expect, and then of course an image intensifier, most of these fractures can be treated conservatively plus minus K-bar fixation. So the learning objectives here is to identify which hand fractures are suitable for conservative care. Select the correct splint and cast and safe position for immobilization. And I'm talking of this because, as I told you, very early in the management, you need to go through the therapy. Plan reduction and follow-up with imaging, complications and surveillance. Outline rehab milestones, and the patient instructions has to be followed carefully. Now, stable extra-articular fractures with acceptable alignment. Stable extra-articular fractures, not intra-articular, extra-articular fractures with acceptable alignment. So you have seen the radiology pictures. You can understand that there are certain fractures which are para-articular or juxta-articular, not involving the articular surface, and are stable. That means there is no strong tendon attached to the para-articular fragment that they can be displaced. Minimal displacement or angulation, no rotational deformity. A small amount of angulation is acceptable, but no amount of rotational deformity is acceptable. A patient who is cooperative and is capable of coming for follow-up visits. When not to treat conservatively is open fractures, bite injuries, or vascular compromise. Intra-articular step off or subluxation like the Bennett and the Rolandos. Irreducible, unstable fracture, significant malrotation, polytrauma, compartment syndrome, or tendon, those associated with tendon and nerve injuries. These are not where you treat this conservatively. Metacarpal, so fracture stability and acceptable alignment, a typical guideline is metacarpal neck up to 40 to 60 degree of volar angulation in fifth, the boxer's fracture. Less in radial raise, more in the ulnar raise. Fourth and fifth metacarpal you accept, but not in second and third metacarpal necks. Metacarpal shafts 10 to 20 degrees of angulation, ulnar more than the radial tolerated. Hope you understand this. You are not very strict in the fractures which are modestly angulated on the fourth and fifth metacarpal. But coming to the second and third, you do not. Distal tuft, usually splint, mallet requires strict this in these mallet fingers, the small avulsion fractures of the attachment of the extensor tendon. If you see a radiograph, you feel tempted to open up and fix so that you avoid this frog splint and then all kinds of complications. But if you open up and then you try to fix with a mini screw, however thin the diameter is, there is a fair possibility of breaking it open. Sometimes even the K-wire, the thinnest K-wire can break it open. So if you find this fragment is very small, it is always better to go with a frog splint and don't try to open and try to fix with a screw or a wire. The mechanism, assessment and history of examination. The mechanism like punch, crush, hyperextension, hand dominance. Obviously, you would like to be more careful about the right hand on a right-handed person. Look, swelling, wounds, feel, tenderness of the fracture sites. And and to assess the active and passive range of motion and check rotation, neurovascular examination. So this is about an examination of the hand. But more important, salient feature is if you have a swollen finger or a badly swollen hand and you decide on an open reduction on a case which could be managed conservatively but can also be managed by open reduction, choose the former. The amount of soft tissue injury there is going to be difficult if you are adding an insult to the injury which is already existing. No surgery can be done without trauma. And if the finger or the hand is injured and you add, supposing there is a second and fourth metacarpal fracture, already swollen hand. So you want to open at two places. If you are struggling to open in the midline, single midline dorsal incision, and you want to go to the second and the fourth, I don't think you are doing justice to the patient. Maybe you could just fix one and come out. Try to fix the one which is most displaced. Try to be conservative with the one which is least displaced. So, true PA lateral, it has already been discussed. You must sit with your radiologist colleague to understand how to interpret fractures, especially the wrist fractures, the scaphoid fractures, the scapholunate dislocation, scapholunate disruption, the lunate and perilunate fracture dislocations. So those are the things you should try to understand sitting with your radiology colleague, and therefore, if you are not able to get a clear picture on the radiograph, ask him to come to the operation theater where he can demonstrate the fracture to you through a image intensifier. So you can move the picture tube closer or away from the injured hand to have a bigger or a smaller picture. So you can opt for a bigger picture, ask your radiology colleagues to explain you where the fracture is, if you are not able to see the fracture after I've opened it. So these are typically fractures which are treated conservatively without any doubt. But should you have a fracture here, see this is what I refer to as a para-articular fracture. It has not gone into the joint. If you are not sure, ask for a bigger image or go for a CT scan. But should you open this, you will have a lot of difficulty in fixing it unless you do a lot of periosteal and soft tissue stripping, which I would not advise. If a fracture is oblique like this, you have to go from the side, and you may opt for going through a mid-axial incision, or if you go through this midline split extensor tendon incision, you have to go far on one side, stripping a lot of periosteum and increasing his misery. So this is another such fracture. If you can give a metacarpal cast, follow up with a splintage and therapy, you can come away. The same thing can also be fixed with a plate and screw, but I don't think it is essential to put them. See, this fracture is in the capitate bone. Should you open it? No chance. This is a typical boxer's fracture. There are two pictures. One on your left is an angulated fracture. The one on your right is with a very modest angulation. So you cannot say a boxer fracture or a metacarpal neck fracture I will treat by conservative or surgical, depends on what is the case. If you can reduce this fracture, it still can get angulated because of the strong flexor pull. You need to put two fine K-wires, distal to proximal, put it there, apply a slab, come out. No need to open them up. So this is another example. There are many examples. You know, these are, you'll know that this fracture is calling for close conservative approach. And there are certain fractures. So these are different, this is a Bennett fracture. This is not a Bennett, a Roland, 3-piece. Okay? So can this be treated conservatively? In fact, this patient was treated conservatively, and he was a gynecologist. He came out happy with the end results. Good range of movement. I had given traction to this finger for a while, and weeks later, reduced the amount of traction and then mobilized the finger. She did not want this to be operated. So there are various splints. Body strapping is the simplest splint. You can like have immobilization for one finger, for two fingers, for three fingers, for four fingers, and so on. So adequate analgesia, hematoma block, gentle sustained traction, and correct deformity, apex, volar angulation, flex MCP, push dorsal to volar, check rotation clinically, re-reduce if any surgery is required, post-reduction radiographs before final immobilization. So this is a very vague kind of slide, but it tells you that you cannot come out before you are happy with your reduction. So if you are not able to reduce a fracture, so there is no role of a conservative treatment in it. So all said and done, if you find that the fracture is not reduced to your satisfaction, then probably you need to go up. So therefore, like in laparoscopic surgery, we say 99% I will go through the laparoscope and come out. Here we say 90% chances that I will come out without operating, but 10% chances that I might have to open up. Immobilization duration, metacarpal neck and shaft 3 to 4 weeks, as I said, but these are all intermittent. These are not 3 to 4 weeks at one go. proximal, middle. So they're all like 3 weeks is the standard thing bred in our mind that 3 weeks immobilization is essential. But in hand cases, this need not be true. You can start mobilizing the hand after 7 days, after 10 days, after 15 days, depending on the stability that this fracture has. Follow-up and imaging schedule. Yes. So what is the follow-up and imaging schedule? As I said, I would like to see these patients every week. Every Wednesday is our hand clinic, and we would like to see them every Wednesday. In case I find that things are not very good, maybe I will go back and give a little local anesthesia, put a small K-wire. I am very liberal with K-wires. They don't cost you anything. 200 rupees is the cost of a great quality of K-wire. And you can use one K-wire in 2 pieces, break it in the middle, but all you need is a good pin introduction or a pin collet. So Synthes pin collet will be anywhere around 7.5 lakhs rupees. Bell pin collet will be like 3.5. And if you take an Indian, I'm forgetting the name, it is about 1.5 lakhs rupees. So from 1.5 to 7.5, you have a high-speed drill with a pin collet, which has this ease of moving back and forth. And you can go in 5 millimeter into a small fragment when you don't need more. But without these 2 things, probably it will not be a nice proposition to start treating with K-wires. So I do not go into the details. All I need to tell you is most fractures can be treated conservatively, but not all. And even if you have started treating a patient conservatively, do not hesitate to go in and put in a K-wire if you find them getting displaced in your weekly checkups. So phalanges and everything is almost the same. Thumb and scaphoid, all these are for theory purposes. So I hope more and more plastic surgeons start managing the skeletal injuries of the hand. They are not as difficult as joint replacements or knee fractures or hip fractures. They are very simple fractures. You can always treat them. You don't have to call an orthopedic surgeon for this job. So pediatric consideration, most again, or almost like 99% we go conservative. Complications to watch: loss of reduction, malnutrition, stiffness, complex regional pain syndrome, sometimes which comes when the patient is not very complying type, is not moving the hands the way you want them to move, tendon adhesions, mallet, all kinds of things. Non-union is rare in fractures of the hand. Non-union is rare in the fractures of the hand. Malunion is very common in the fractures around the distal ulnar and needle fractures. But again, there are umpteen number of volar distal radius plating system in this world, unending. The motto of the last Asia Pacific hand surgery meet was progress with purpose. Progress, but with a purpose. So now nobody in this world can tell that this is the best device for fixing up a distal radial fracture. It is still going on. But I believe after going through this period of open-rotation internal fixation, I have come back to ligamentotaxis, which is traction across the wrist joint. Fixing this distal radius fracture with multiple K-wires has given a very satisfying result to me and to my patients. So rehabilitation, return to function. Okay, so these are the things that I would like to tell after working in a time where there was no internal fixation device for the hand in the 1980s, to 90s and 20s where there were umpteen number of devices to fix, to after 45 years of my work, dwell more on external fixators and K-wires to treat all these fractures. Thank you.
I now have the privilege to introduce Dr. Mohammad Tahir Ansari, sir, Professor of Orthopedics at AIIMS, New Delhi. He began his journey with AIIMS as a postgraduate and has since served in various faculty roles, building over 2 decades of experience with a focus on upper extremity surgery. Dr. Ansari trained under the renowned Professor P. Kotwal, a doyen in the field of hand surgery, and further honed his skills at the Kaplan Hand Institute in Barcelona, earning the European Diploma in Hand Surgery. With more than 50 scientific publications and a deep dedication to clinical practice and education, Dr. Ansari continues to mentor the next generation of surgeons. I request you, sir, to kindly present the next talk on general principles of hand fracture fixation.
Village to T2 as my and I call all of you as a generation. So just I'll ask you one MCQ before every lecture so that you all are engaged. Okay? These will be very simple MCQs. The MCQ for this lecture is which fracture has got highest propensity for rotational malalignment? Option A, metacarpal. Option B, proximal phalanx, you can call it P1. Option C, it's P2, means middle phalanx. And option D is distal phalanx or P3. Anybody? It's metacarpal. Okay? So just remember it. And just a quick recall of the principle of fixation. Once you see these fractures, you should divide in 2 categories. One is displaced, undisplaced. Second is stable, unstable. Whole concept revolves around these 2 principles only: stable, unstable, displaced, undisplaced. Okay? To start with, as sir has told us, the main treatment is conservative treatment. But you see, there are certain indications where you have to fix. You just must have noticed a simple carpenter or any other worker coming to your home for some simple work. He must be coming with different tools. Okay? Those tools are used for a specific purpose. Similarly, as a doctor, we should have all the options and should utilize those options where there are certain indications. Not in every case. So similarly, if you have these screws and plates, you should know when to use it and how to use it. So so this is an exam question for you. Your examiner will ask you, what is a screw? So a screw is a device, powerful mechanical device that converts a rotation into linear motion. What does that mean practically? If you are applying a screw in your OT, and you are using your shoulder and elbow, you are doing something wrong. The force should from your hand and wrist. So just a technical tip how to use this screw. Actually, the screwdriver, use 3 fingers and rotate it. If you are using force more than that, there's something wrong in your surgery because you are not utilizing this basic principle, which simply means rotation should be converted into a linear motion. So exam question as well as practical tip. Should know these parts of a screw, actually it has got tip which may be a different type. A central core thread which will be larger. The strength will be provided by the central core. Larger the core, more is the strength. And thread, different types of threads, they will have purchase in the bone. And definitely the head, because you must have removed lots of plates or screws from the patients. If you don't know the head part, you will miss the screwdriver. Okay, so it's very important to know the screw design. It may be cancellous type or cortical, that we will discuss. It may be partially threaded or fully threaded. It all depends upon the whether it's fully threaded, the threads are there. The thread length or the thread diameter is larger, and two threads, there are more distance. The pitch, that's called, partially threaded, are mostly used for fixation of leg screws. So sir has just told us how to use these screws. You should be in that plane actually. And what should be the length of that screw? So once you will see those screws, you will see the distal part, a flute out there, and a conical tip. That should be just up. It should not be short. Otherwise, the screw will not pull the distal fragment. So it's essential how much long screw should be used. And I have told you about the pitch because it's different for a cortical bone or a cancellous bone. These are different. And the screw head, if you see, mainly these are in three types. You will have the star-shaped, that one. You should have, if you are going to remove your screw, then you should have appropriate screwdriver. Otherwise, you will stuck in the case. So this is star shape, then the hexagonal shape, and that's the square shape. So you should have these screwdrivers inside your part also, because that can be utilized in your case. And this is a screw differential pitch. What does it mean? These are mainly utilized for fracture. So the pitch is more, the thread length is more here and less in the proximal part. So this part advances more, this part advances less. Oh. So that will lead to compression. These are called headless screw. The main indication is for scaphoid fracture. Okay. Then again, the self-tapping screws, it simply means there's a flute out there. If you see that part, that's the flute, that's self-tapping, that has to be out. What does it mean? If it has to engage in the distal part of the bone, that part should be out of the bone and this thread should be in the distal cortex. And these are self-drilling. That means the conical tip, a fine tip is there to drill. You don't need to drill the far cortex. So that this screw will go by itself. Then again, you have to take this part, a longer part, out of the bone. So you should know the design of this screw. Then you can definitely, and plates, we know the compression plate. Why these are called compression plates? You should know how to utilize these plates. These plates, whenever you are using, provides compression when you apply an eccentric screw. What does it mean? The screw is being applied in the far part of the oblong hole. That will lead to compression. Okay, we will discuss it further. So these are mainly used for dynamic compression plates. Again, the next generation has come up, the locking compression plates, where the screw gets engaged on the plate itself. It acts as an internal fixator out there. It provides a uniform compression, a uniform stability. You must have remembered in your physics class 11, 12, the parallel connection and the series connection, actually, serial connection of electricity. It's similar to that, similar to parallel connection. The wire is coming and different wires are going into the different electricity instruments. Similarly here, the screws are getting engaged to the plate as a locked. So these are the types of plate that we have discussed. Then coming to the reconstruction plate, these are mainly used for forearm or elbow. And buttress plate, what does it mean? It provides compression with the help of, you apply a screw proximal distal to the main bone that leads to compression of the fractured part. How can it be utilized? It can be utilized as a compression mode, buttress mode, or bridge mode. So compression mode we have discussed just now. Most commonly we will see a buttress mode or utilization mode. What does it mean? Utilization mode means you have applied the leg screw plate. That protects your fixation. The buttress mode, it supports the artificial part and prevents the collapse of the part. So it supports the forces. For example, in this case, you see what has happened. If you see a mallet finger, this is a large fragment out there. Then you can apply a buttress. The hooks are just supporting the fragment, and this screw is to the cortical bone, leading to compression fracture part and achieve this articular congruity. Obviously, these plates are very near to the nail plate, and you have to remove these plates around. So we have removed the plate, and this is again that uh, radiographer appearance of the picture. Then again, this patient, if you see, this patient has a proximal PIP fracture dislocation actually. So one of the way of utilizing, you obviously Suzuki frame, we will do that also. But in acute fracture, maybe around 4 to 6 weeks, you can apply a plate in the buttress cord again. So that you can achieve the compression and achieve a joint congruity in the phalanx. This is one of the you can achieve range of motion immediately after applying buttress cord. So for phalanx, for periarticular fractures, the buttress cord you should know. Then the bridge mode. If you see, there's a lots of combination out there. So the bridge mode means you are bypassing this comminuted part, you are applying few screws here, achieving the rotation, then applying the distal screws. So this is bridge mode is especially for comminuted fractures, unstable fractures. The indications are very rare, but definitely you should know this technique because not all patients will be the same. Sometimes you will have that kind of presentation. Then you can apply the plate as a tension band principle, where you have to apply the plate in the metacarpal. You have to apply the dorsal surface of the metacarpal. So what is pre-bending of the plate? So this is a very basic principle if you want to apply plate in metacarpal leg. What you bend the plate a little bit, slightly, maybe or so. Once you apply the screws, that will lead to compression over the far cortex. So this is very important concept of applying plate as a tension band, that's called. Otherwise, it will lead to distraction at the fracture. So how to apply the screws? Whether from near to far, from the fracture site, or from and why so? Plate as a that will lead to compression here. If you start applying the screws from distal to proximal, from this part you start, then the fracture distraction will happen. You never ever do it. So you should know how to use the plate as a tension band principle, apply screws, and in which apply the screws. So we just told you this thing. Then we go away from the fracture. And coming to the locking plates, actually I just explained you. So what are the different sides of plates? We can always apply anywhere. But for compression mode or tension band, you apply on the dorsal surface of the bone, especially the metacarpals. And the locking plate can be applied anywhere. It may be applied wherever these K wires, these smooth wires or the threaded wires. What is the advantage of threaded wires? These provide more stability, but it's difficult to remove these wires. And depending on the tips, it may be trocar tip, diamond tip, or the cancellous. Then you should know how to use these K wires, cross K wires, parallel wires, intramedullary bouquet technique, transarticular tension wire principle. It was managed with the help of K wire. These are unstable fracture in the proximal patient. This is the cross. This is extrafocal. We are coming from the bone to the proximal. We are going through the fracture site. So from where you should start? So that the wire will push the distal fragment and reduce that fragment. For example, here fracture, other is coming away from the fractures. Then how to make these? So whenever you want to provide a stable fixation. Sometimes we see lots of patients are coming with K wires, but in different configuration actually. These wires should cross away from the fracture. If the fracture is here, you don't apply the wires so that the crossing is happening proximal. So always remember this small cross fracture. Only then these wires will be stable. We have already discussed, we will discuss in the lecture the follows technique. We all know how to do that. Just put one wire, block fragment, and how it's going on. How you check it under the image again. You see, extend it and then put 1K wire just beneath the nail bed. Your distal phalanx is not in the center. It's just beneath the nail plate, around 5 to 6 mm beneath that. These are a little bit larger wire. You should use around 1 mm or 0.8 mm wires. And just transfix the DIP joint. One technique is fixation to another metacarpal. Okay, so we will discuss it later. And then the other use of K wire is the use as an external fixator. So for example, this one you apply Suzuki frame, we will discuss in the lecture, and then we will see on the table itself. Thank you. Especially the technical part, you should be well aware of it.
Excuse me, did you have any protocol for fixation of the phalanges and also for the metacarpal?
Sir, for protocol, as I have told you initially, it depends upon whether these are stable fracture, unstable fractures. All stable fractures are managed in plaster or splints. If these are unstable fracture, which simply means comminuted fracture, oblique fractures, multiple fractures, intra-articular displaced fracture, those are coming in the unstable category. And fix those fractures. Whether it's
Second question, mostly in the amputated parts of the phalanx, I mean in the fingers. So what about the fixation part?
most commonly we use the K wires, but we use 2 K wires, not 1 wire. 1 wire will provide rotation stability. So use 2 K wires.
Repair which has been done, that can be hampered with the rotation.
Yes, use 2 K wires. Provide stability. Yes. It may be because of both of these, both the factors may be there, but most of the plates in digits are removed within 6 months. Yeah, actually, if you see the papers, actually, if you categorize 4 types of fixation, one is smooth K wires, 2 smooth K wires. Second is 2 threaded K wires. Third is 2 screws in non-leg compression mode. Just you put 2 screws. And the fourth is you put the screws in leg screw pattern. So stability wise, logically, no difference at all.
So in answer to your question, you will want a threaded screw because a smooth pin will not give you compression. It will just be a holding pin. So then you have to apply some external compression using a clamp or something, hold the bone compressed while you are holding with a smooth pin. You can use smooth pins in different configurations to hold the reduction. But a threaded screw or a screw or a threaded K wire will give you compression.
So what I think is that sometimes we take out and manipulate
protection will be very difficult with the threaded K wire. So it basically all K wires with experience will come. It will be single shot. In twice, in thrice, in 4 times, but shoot once.
So as an orthopedic surgeon, what is the most common use of threaded K wires for me? It's for interarticular fractures in distal elbow or so, where it's difficult to achieve fixation with the help of screw or so. We put the threaded wires and cut it flush. That's the indication. Literature-wise, if you see evidence-based medicine, there's no difference. Compound fractures are a different ball game actually. The first is you don't apply any internal fixation because there is a very high chance of infection. So these are managed with the help of external fixators or external fixators plus few K wires. I'll again say few, means few. For revascularization, 2 K wires, then you obviously there's more urgency of doing a vascular repair rather than wasting your time applying a plate out there. For example, there's a fracture of, there's an amputation of the middle phalanx or proximal phalanx. You put one intermedullary K wire directly, other extra-articular wire to provide the rotational stability, then you do a vascular repair. If the
Priority is to give the bone stability, just a skeletal stability. You're not aiming for a perfect reduction or a perfect function. You are just creating the scaffold so that the anatomical sort of contour is restored, you can do the vascular. So that is the priority. The bone doesn't need to be perfectly aligned. You're not thinking about long-term function. You're just keeping it stable so it doesn't wobble around, affect your whatever sort of.
okay, let us come for the coffee.
Faculty member of the AO Trauma and an associate member of the Faculty of Surgical Trainers at the Royal College of Surgeons, Edinburgh. Beyond his distinguished medical career, he brings creativity as the keyboardist and manager of the osteoblast.
Okay, so after the coffee break, we now slowly start getting into the nitty-gritty of actual fracture fixation. We talk a little bit more in depth about the various implants used. So there's a very famous, quote in hand surgery. I think it was attributed to Dr. Sterling Bunnell and also to another orthopedic surgeon by the name of Dr. Flatt. And the saying goes something like this, that hand fractures can be complicated by deformity from no treatment, stiffness from over treatment, and both stiffness and deformity by over treatment. So, with that in mind, the hand is a very unforgiving kind of, so it doesn't give margin for error. So the first time is probably the best time to get it right. So pay attention, because this humble, versatile implant is going to save you many a time. So if you know the principles of usage of proper K-wire usage, also, then you can use it more effectively. End of the day, it is the principles which matter. It doesn't matter if you are using K-wires or don't have to use the latest gadgets or inventory all the time. If you're good at using even K-wires, many a time maximum fractures you can get away with very good results as long as the principles are followed. Okay. So, a little bit about the history. First of all, look at this injury. When you come into casualty and you're called to see something like this, the first thing you think is, oh my God, what am I going to do? And this also is compounded by the fact that if this hand happens to be your consultant colleague in the same hospital, then you can imagine the added amount of pressure that comes upon you as a hand surgeon. Because before you even go to the casualty, you get 50 phone calls. Is his hand going to survive? What is going to do? Is his career going to be threatened? Are you going to cut the finger? What are you going to do? How are you going to do? Are you going to do plastic surgery? Should I call another consultant? Will you be able to handle it? Do you need someone else to join you? Etc. etc. So no pressure. Okay, we'll come back to this slide. Take a good look. We'll come back to this slide at the end of the talk. So the learning objectives of this talk are, we're going to learn a little bit about the different types of KYs. We're going to talk about the principles of the use, and then maybe see a specific applications in hand surgery. There are extensive applications, but we're only going to cover a few basic ones because in the interest of time. Okay. So general considerations, well, the K-wire was introduced to us as an implant in 1909, usually made up of stainless steel. So this is Martin Kirschner. And the name K-wire comes from his name, Kirschner wire, abbreviated as K-wires. So they are usually in various forms. They can be threaded, but if you go by the tip, you can have a trocar tip or a diamond tip. A trocar is a trip like a Mercedes-Benz. A diamond is like double slant on both sides. Diamond is more applicable in cancellous bone. Trocar is the one which we most commonly use for cortical bone, made up of stainless steel or titanium alloy. And in hand, the commonest diameters which we use are 0.8 millimeter, 1 millimeter, and 1.2. Larger diameters are seldom used in hand surgery, maybe in the wrist, yes. But for fingers, hands, mostly these diameters. Versatile application, as you shall see in the following slides. So, the advantages are several. They are very cheap, easily available. You heard Dr. Subrat Janar speak to us about KYs and how his philosophy has changed. He's gone back to doing a lot of KYs. I also tend to feel the same. If used effectively, there are a lot of situations where you can get away. You don't necessarily need to use plates and screws all the time. They can be inserted with a T-handle or a drill. If you have a power drill, a lightweight one with a pin collet, that's very easy to insert KYs, and they're easy to remove. You can remove them in OPD easily. It doesn't require a separate surgical procedure. The disadvantages are they're not functionally very stable. So single K-wire might not give rotational stability. You might have to use cross K-wire. They don't offer compression at the fracture site. So you will have to at least create the compression by using a clamp before you use the pins to hold the position only. And then there's always the risk of pin track infection and the loosening and backing out. So before we start, I want you to commit this slide to memory. It's by one of our colleagues, Dr. Rex, and he has written a book on K-wiring and various indications for K-wiring. But this is a slide which shows you the safe corridors for K-wire entry in the hand. A very important slide. So this is the hand in flexion, and the green areas are the one which we can see are the safe corridors. This is the finger in extension. If you're pinning the finger in extension, you have to be aware of these green areas here. These are the safe corridors. This is with the finger in flexion. these are the parts where you don't have any vital tendons or neurovascular bundles or anyway, so you can actually pass through the skin percutaneously, and if the KY enters through these green areas, you're relatively safe. The risk of infection, etc., much of adhesions, etc., or causing damage to the neurovascular bundles or tendon adhesions, etc., are much reduced. Similarly, if you look at the fingertips, you can put your KY through this without causing too much damage, as you would see in a mallet finger, one video Dr. Ansari already showed. So these are the safe corridors for K-wiring in phalangeal fractures. So the inventory is very simple. It would help if you had this kind of drill with a pin collet. So this will allow you to advance without having to use a chuck key to loosen and advance the K-wire every time you want to. So this pin collet is very handy. Apart from that, K-wires are extremely cheap, and some battery held versions, the Indian are very available very cheaply and readily. You need a good pair of fine pliers to bend, and cutter also. So K-wire benders and cutters. Nose pliers are very useful. So this is all the inventory that you need. Some of the general considerations. The collet is very useful. You have to keep the K-wire length short when you're drilling. Otherwise, they tend to toggle. What do I mean by this? So if you have something like this, with the K-wire protruding like this, and you're trying to drill, and invariably when you're trying to drill into a bone, you have a tendency to help the drill by putting a little bit of pressure also. The K-wire will tend to bend. So you invariably have the tendency to help. The idea is to let the drill do the work. You don't apply extra pressure. You are applying a little bit of extra pressure is not going to help your case. It's going to make things worse. It is going to cause the K-wire to skid off the bone. So just have a sharp drill, sharp K-wire. It has not been reused preferably. You will be able to get your entry very easily. Keep it short. So this is the correct way. Keep it too long, it is going to wobble. If you keep it like this, it's going to be the correct way. You can control the trajectory also. And if you have a collet, then you can advance it without having to unscrew the key. The other thing is you have to realize, especially in thick cortical bone in young patients, when you're drilling, it creates a lot of heat. We don't realize it, but it causes a lot of the bone at the point of entry. So if you have thermal necrosis of the bone at the point of entry, your K-wire is going to back out or loosen very easily. So while you're drilling, it's a good idea to get it with a syringe, irrigate the tip of entry so that the K-wire doesn't get and no to the bone. These are small points to consider, but if you want your infection 6 weeks, it's thing. Now, about the entry point. We refer to this as a nick and spread technique. Don't directly go. Use a small mosquito. The hand manually on the bone at your side. Put the drill on and then start drilling. If you start directly drilling into the skin, it's going to catch some, it will be a cutaneous nerve, but it might catch in your bone will heal, but the patient is going to complain of a painful scar all the time. So small things like this, a nick and spread technique, it's a safe way, prevents spin track infection also. Always start, preferably wherever possible, from the small fragment, go into the larger fragment, not from the large fragment to the smaller. The reason being, once you get a purchase in the small fragment, you can use the K-wire as a joystick to actually guide it and reduce the small fracture onto the bigger fragment. So, as a rule, whenever you can, start with the smaller fragment and go into the larger fragment. Okay? Next. For biomechanical stability, try and go as far as possible perpendicular to the fracture site. So if you go like this, you're almost perpendicular to the fracture site, or as close as perpendicular to the fracture site. So this will give you good stability. We have the mobile switched off, please. Okay. Now, if you have a transverse fracture, you can use cross K-wires. And if they cross, they should cross beyond the fracture site. They should cross earlier, like Dr. Ansari said in his talk earlier. So, we had seen the slide previous. So the point of crossing should be beyond the fracture site. And at this fracture site, if you divide the fracture into thirds, one third, one third, one third, then at least there should be a third of the fracture width of the whole bone should be the gap between the K wires. Do you understand what I'm trying to say? So the K wires, there should be spacing. It's no point putting two K wires crossing very close to each other because they will swivel and pivot on each other. Almost similar to having one single K wire. So if you want a little bit more rotational stability, as well as transitional stability, then you have to space the K wires and they have to cross beyond the fracture site, and there should be at least a third of the width of the entire bone in between the K wires. Okay, I'll share the PowerPoint with you. Don't bother writing, just pay attention. I will post it on the WhatsApp group. If you want, you can download and see for your reference later on. So K wires should be spread apart, greater than one third of the fracture width. I've already told you this. Now what happens if the fracture is not transverse? God is not always kind to us. He gives us fracture in all kinds of perplexing configurations and then expects us to treat them with K wires. Do we say no? No, we rise up to the challenge. What do? You have an oblique fracture greater than 30 degrees, something like this. Can you do a cross K wire? Now what is happening to this K wire? This is almost parallel to the fracture site. Is it going to give you stability? No. So you have to rethink this cross K wire fracture configuration. You can't have a prefix idea, I'm going to treat all my finger fractures with cross K wires. If the fracture is oblique, greater than 30 degrees, then you can't use this. Then what do? There is a way. So because one K wire is running parallel to the fracture surface, this is no good. What do? We use from one side divergent monolateral K wires. What do I mean? Something like this. So entry point is close by, but you get the K wires to diverge. So both are crossing almost at 90 degrees, but from the same side. This will give you more stability than cross K wires in this kind of configuration. Then you might ask, sir, what if the skin here is infected and I can't put my skin through this? God gives us all sorts of permutation combinations. Then obviously don't go with the prefix idea, I'm going to use this wire. Use an external fixator or some other treatment modality. You have to be flexible to adapt as per the requirement of that individual fracture and the soft tissue. So if the soft tissue is unsuitable, use a different method of fixation. Okay. So spacing of the wires, I've told you already a little bit about this. So wires should be spaced as far apart as possible. So compared to this is better because this is spaced even more apart. Ideally 1/3 to half the fracture width. So if you take the whole width of this and this is say 10 centimeters, then your wire should be at least 3.5 to 5 centimeters apart. So when you're using this percutaneously, sometimes a drill sleeve is useful. You can place the drill sleeve against the bone and then drill through it. That way you're protecting the soft tissue and also you're helping to control the direction of the K wire with the drill sleeve. Fine drill sleeves are available. So sometimes what happens is because of this, especially in the finger when you're entering through this area, which is a curved bone, you will tend to skid off, especially if your trajectory happens to be almost in the long axis of the bone. So for that, one trick is to go a little bit perpendicular, just get the tip to engage the cartilage here or the bone here, the cortical bone. Once the tip of the K wire has engaged the bone and it is unlikely to skid, then you can change the direction slightly and then get it to go wherever you want. Instead of trying to start in an oblique direction, you will invariably skid off the bone. Just make a small sort of purchase in the cortex with the drill, and once your drill bit, the K wire tip has engaged the bone, you can change the direction accordingly. So that is another useful tip. Always check the position on tube views. It is often commonly you think the K wire has gone nicely when you don't take a lateral view and you see the K wire sitting out. It might look very nice on one view, but unless you take C-arm pictures in orthogonal views, you will often find that the K wire is not going where you want it to go. And always make sure that on the other side you see the tip. So if you rotate it like this slightly, this is called bicortical purchase. So this cortex also it has engaged, and that also it has engaged, and with a little bit of experience you will get that feel when you're drilling, that slight loss of resistance the second cortex, but don't go too much because the soft is on the other side. Okay. So even the good things have complications. Not everything is good about K wires. Yeah, they are very useful, they are very handy, but you should know how to use them. But some things can go wrong and you should be aware, so that the idea is to avoid them. So sometimes if the fracture configuration is such and you have not followed the principles properly, you might get loss of reduction. And with that, with the patient moving and everything, the K-wire was also very thin, and this K-wire broke, and there was a little bit of loss of reduction. It's not very evident on the X-ray, but then at the time of removal, this is what happened. One K-wire came out completely, and the other one, you can see the tip, it's broken. So if it is broken inside the bone, it's a nightmare to remove it, and the patient will always complain, Doctor Sahab, ye kya ho gaya, andar reh gaya, koi problem to nahi hoga, and then you spend the entire next 45 minutes trying to explain what can go wrong, what will not go wrong, but the patient is concerned. You can have migration of the smooth K-wires. So smooth K-wires can migrate. This is a supracondylar fracture in an elbow in a pediatric patient. The K-wire has migrated, and I don't even want to think what that tip of the K-wire is doing in the front of the elbow. Yeah, it's scary when you see something like that. You can get pin track infections. If this is not, so thermal necrosis might be the cases, diabetic patients, and if you have made multiple attempts at drilling and then withdrawn, drilled again, K-wire becomes loose, skin bacterial colonization at this site, pin track infection, and then before 3 weeks you will see some osteolysis, some drops of pus coming out, you have to take out, the fixation will be lost. A lot of problems can happen unless you are careful. So let us assume that you have let us see some practical use the K-wires in phalangeal fractures. So specific applications, the first thing, Dr. Ansari has beautifully showed us a video where he has done a, extension block pinning. It is also called Ishiguro technique after the Japanese person who described it. Ishiguro's technique is basically extension block pinning. If you get a bony mallet finger with a relatively congruent joint on a fragment like this, Dr. Subrat Jana in his talk said if you try to put a K-wire through this, it might fragment, or if you put a screw through this, it might fragment. So we can use or you can use a splint, but keeping on a splint in the Indian context when there is sweating and, warm temperature and patient compliance with the splint is going to poor. Anything which can be removed will be removed by the patient. That's a dictum in hand surgery almost. You can't rely on patients for compliance. So they will come and say, I removed it only for 2 minutes when I went to have a bath for 5 minutes. And that 5 minutes will bring it back again to normal, back to square one, because the FDP is a very powerful tendon. So this is a very simple way. I will have a video here, which will show you the principle. I don't know if it's playing. How do we get this to play? Okay, you can see it's playing. So first thing, you bend the fingertip, get the K-wire, not engaging the fragment, just proximal to the fragment into the head. And then you extend this finger, this reduces it, and then you pass an axial K-wire like this. So basically what this K-wire is doing, it is an extension block. It is preventing this extensor tendon from pulling on the fragment. When you bend it, it comes back to its original position. You get this K-wire as an extension block. Then you straighten the larger fragment and pass an axial K-wire. And this is how the extension block pinning is done. How does it look in a real life scenario? So this is the fracture. After the extension block pinning, this is what it looks like. And this patient will go on to heal nicely. K-wires can be removed at 4 weeks, and then you can supplement with a splint for a few days more. 6 weeks is the healing time, and then you can commence mobilization. The same principle can be applied when there is a central slip avulsion, bony avulsion of the central slip, but here this is not the distal DIP joint, this is the PIP joint, and this is the base of the. So what happens if this is not done? What deformity will you get? Louder? Yeah, be confident. This is a very safe environment. You are allowed to say whatever comes. You can even say swan neck, I won't mind. Boutonniere deformity, correct. Okay, so what do we do? Patient has no money. You have very little time. What can we do? Okay, we do this. How does this advance now? Okay, so same thing. You can change the configuration. Basically, you need a transarticular wire to sort of immobilize the joint in extension, and you have added this K-wire as a, as an extension block so that the fragment stays in place. See a clinical application. This is that thing, extension block. This is holding the extension. Notice that the pin is not going through the fragment, just proximal to it, yeah. And this is just a transarticular wire. It is not, I didn't use a transarticular wire. This was another fragment here. So I'm holding this to the, because it was a large fragment. So this is doing the job. So this is basically an extension block. You may or may not opt to use a transarticular wire. It's not mandatory. Let's come to transverse short oblique fractures, something like this. This can be treated conservatively if it's stable. You can strap it, neighbor strap it, put a splint. You can treat it in many ways. K-wire is one of the methods if you don't want to risk. The problem with any conservative method is it has to be done exactly right, and it involves a lot of follow-up. You have to weekly X-ray it and see that there is no secondary loss of reduction. Because if you ask the patient, come back after 1 month, and what you think is a stable fracture has actually slipped, then the patient is not going to forgive you. So sometimes it's better to put a K-wire, and at least you are sleeping well at night, that's not going to displace. So it's a relative indication, but anyway. So for transverse oblique fractures, you can use cross K-wires like this. Again, you have to make sure the principles are followed. A fracture like this, you can treat with conservatively. You can use a screw also, but in this case, we use K-wires, cross K-wires, and that patient went on to do well. For partial articular fractures, you have to be very careful with the fracture which is just involving the condyle, because even a 0.5 millimeter or 1 millimeter loss of reduction at the joint surface because of the long sort of axis here will cause a significant angulation deformity, distally. So 1 millimeter step at the PIP joint will give you at least 10 degrees, 15 degrees angulation more distally. So even if there's a slight step, this articular condylar fracture has to be anatomically reduced, and often it can be done indirectly. What we need to do is give, valgus stress in the opposite direction, get it to go this way, and then you can use a clamp. Very useful, and I advise all of you to invest in it. It used to cost 2,500 when I bought it, but now it's gone up 4,000, 5,000 rupees. It's a radiolucent clamp for K-wire fixation. Buy it on any of the hand conferences. It's the best piece of investment you will ever make in your career. I'm telling you, it's so handy. You can put the clamp here, get it reduced, and through the hole in the clamp, you can actually put your K-wire without losing compression. Yeah, so this is what we went on to do. This is a partial articular fracture. This is one configuration. One is transverse, one is like this. This will give you stability in this wall fragment. Because if you put two parallel, it might not be enough. So this is a fracture, same kind of fracture. One condyle gone like this. So what I did was this. So I put two K-wires, but I put another oblique fracture across, and you can see that this is nicely healing, and there's a good articular reduction here. Patient went on to do well. Spiral fractures, you have fractures like this, provided you are lucky to get it within the safe zone. Obviously, you can't start putting volar wires through the flexor tendons, through the neurovascular bundle. Not all fractures are amenable, but if you get it within the safe corridor, you can still attempt to fix a spiral fracture with K-wires. And this is such a kind of fracture. You can see it's going like this. And we thought, let's give it a try. And we managed to put these all seem parallel, but they are not parallel. They are slightly off, so the angles. So it's in a slightly spiral configuration. And this is the reduction we managed to get, and the patient went on to do well. Metacarpal neck fracture, we use a combination of a, anti-grade wire from the base. It's like what you would use in a Foucher's technique, a bouquet technique, but instead of multiple K-wires, we use one, and we use separate wires outside. This is another application. This is another fracture. These two neck fractures, and you can see these. So many a time, because I work in a corporate hospital, the expenses go up significantly if you want to go for an open reduction internal fixation. These ones you can do very simply within half an hour. We have a package for a minor surgery which is significantly lower. So for economic reasons, and if you are good at K-wires, you can give them a good results. Patient is happy because the K-wires come out at 3 weeks, 4 weeks. There's no indwelling implant, and they are all happy with the results. So this is the fracture you can see. Went on to fix like this. And so it just goes to say that you don't always need plate and screws. You can get away with K-wires, and you can see the reduction. Yeah. So sorry, I just missed one slide. This is a Bennett's fracture. It's an intra-articular fracture of the base of the thumb metacarpal. You have the abductor pollicis longus pulling on the larger fragment, whereas the beak ligament, anterior oblique ligament, is holding this fragment in place. So that is why the displacement happens in a Bennett's fracture. So to neutralize that, you have to pull on this thumb metacarpal and rotate it to correct the, so you pronate it and you can pass K wires through here. They don't have to necessarily go through the fragment. They can even go proximally into the second metacarpal. They can go through this fragment into the trapezium. It doesn't matter. All it needs to do is, keep this opposed and counter the pull of the APL. So you see the fracture there. We just used 2 K wires. This was a large fragment, so we went into the base of the index metacarpal and the trapezoid here. So that's one way of fixing it. This is a reverse Bennett or a baby Bennett fracture. This is on the 5th metacarpal base. You can see there's a fracture here. The patient also has an incidental P1 base fracture. So both of these were simultaneously treated with K wires. So that is the fixation. Cross finger K wire, cross K wire here, configuration here, and then here same thing, and that reduced the fracture quite nicely. This is a thumb epibasal fracture. So how is it different? The whole articular surface here, it's almost like an extra-articular fracture here. So these are called epibasal extra-articular fractures. Similar principle, almost like a Bennett, because the fragment is large, you can actually go get your K wires through the fragment, and that is how it is fixed. So CMC dislocation, you can see here, very carefully if you see, you can see an overlap of the hamate and the base of the 5th metacarpal, 4th metacarpal here. So these are best seen on a lateral view. You should not miss this because the hand is swollen. It is often missed, especially in a polytrauma patient. What happens? Fixed with the K wire, you can see the 5th CMC joint. This is the hamate. You can see the joint space reduced nicely. Perilunate dislocations, we've talked about that. This is the capitate, this is the lunate, it has come off. This is the standard diamond configuration of K wires we use. So this is very effective when once the joint has been reduced by open or closed methods. If it's fresh, you can do a closed reduction. If it's open, if it's a few days old, then you need an open reduction. These are also commonly missed injuries because residents often see this and say no bony injury and send the patient to OPD, and they come 2 weeks later with this sort of thing because the lateral view hasn't been done. Happens mostly in multiple injuries because the hand gets less preference compared to other life-threatening injuries. So once you have reduced, you can use this configuration of K wires. There you have to keep it for 6 weeks though. So you have to be very careful when you're fixing phalangeal and metacarpal fractures. Dr. Ansari said, which is the fracture which gives the maximum rotational deformity. It is the metacarpal fracture. If you think about it, the more proximal it is, the less tolerant it is to malunion. Even a little bit, 5 degree of rotational deformity will magnify at the fingertip into a large arc. It is just like an arc. So a little bit of garbage at the foundation will get the whole building to tilt, like Leaning Tower of Pisa. So you don't want that, yeah? So you might get something like this. So you have to be very careful at the end of every, look at it from the side and see if all the nail beds are aligning, if you can flex the finger. Something you have like the tenodesis effect. If the patient is under anesthesia, you can ask to do that, squeeze the arm here. By tenodesis effect, you will have the fingers falling back. You can check the cascade of fingers to make sure there is no rotational deformity. So coming back to my nuclear medicine colleague, this looks ghastly, but if you look at the X-ray, it's just dislocation. Everything can be put back with K wires. And in the middle of the night, it happened just outside the hospital. He was finishing his duty and going back home, was run over by a bus because his driver didn't come. He was waiting for a cab, an Uber, and a bus came and just bumped him and went over his hand. So no pressure. So I did what I could. We put a flap after that because this skin didn't survive. He's doing very well, but he doesn't come to my OPD for follow-ups. He says, no, it's a very busy man minting money, so he doesn't have time for hand therapy. He says, I'm happy with what I've had. You've saved my finger. It's good enough. So in conclusion, K wires are very versatile implants. They have multiple applications. They are very cheap and easily available. You have to remember the safe corridors used for K wire passage, and the principle should always be followed. Okay? So I'll go on to my next talk, which is external fixators, because it's almost like an extension of the same talk. And once that is done, then we will proceed.
Can I have a question on this?
Sure. Yes, sir. Fire away.
Well, it was a nice presentation.
Thank you, sir.
My question is, K wire, what is the integrity? We have seen there is a fracture of the K wire.
Yes.
So all the K wires available all over pan India
Yes.
are not of the same quality.
Yes, sir.
So So does the quality matters in that?
You have to stick to a reliable supplier, someone who has a good track record of manufacturing. Uh, Most of the time we compromise because we just get whatever is locally available. There is no standard quality control, and most of the time we don't bother because they are reusable K wires. Sometimes the fault is sometimes with us, because sometimes in many institutes we use for provisional fixation. Like we are doing a distal radius fracture, we provisionally fix it with K wires and then put the plate, remove the K wires, then we think it's a perfectly straight wire. And our Indian mentality is jugaad, why should I throw it away? Let's autoclave it and keep it for the next case. And that's how stress shielding, and over a period of time, any implant, there will be metal fatigue and then it will fail you the time where you don't want it to fail. So it's a good idea for fractures to use fresh K wires. These are very cheap. These can be discarded. Not to reuse K wires. Make sure that the tips are always sharp. And also because we are dealing with 0.8 and 1 millimeter K wires, these are tendency to break. Especially transarticular K wires, we should not rely on 1.8 K wire going through the joint thinking that I'm not going to damage articular cartilage. I have to put a supplementary splint across the joint so that 0.8 K wire will break, because the patient is not going to keep the finger like this. He is going to do a little bit of fingering like this and it will break inside the joint and it's a nightmare to take it out. So if you are using a thin K wire across the joint, always splint the joint, be very careful, never trust the patient to follow your instructions. It's always better to be safe and add a little bit of extra splintage externally. Don't reuse your K wires and stick to a reputed manufacturer. In our hospital, Sushruth has been supplying for a very long time, since time immemorial. Their quality, not all of us can afford synthesis K wires, they are very expensive. But there are Indian manufacturers which give reasonable cost, good quality K wires.
Now, how it happens after 2 days, the K wire is automatically removed?
Sorry?
Patient in the rural area.
Yes, sir, it is possible. It is possible.
In that case, how do you manage this case?
Scold the patient first, sir, and then say that is the blame. तुमने सब अपना बर्बाद, अब हमको दोबारा करना पड़े. What can we do? We deal with it as it comes.
Sir, I have a question.
Yes.
If we get an old, like a 2 or 3 month old malunited spinal fracture,
Uh-huh.
the patient is having by and large all movements, but is having some problem on one particular movement, maybe is a pianist or some sort of musician.
दिखाता हूँ ना केस, थोड़ा लास्ट लेक्चर के लिए वेट कर लो, उसमें है केस similar, exactly what you have said, and we have dealt with it in an innovative way. You can do an osteotomy along the plane and put a small plate on it. There's a more easier, neat, quick fix solution. I'll show you in one of the next talks. So let's go to external. Okay, so this we are going to talk a little bit about external fixators. How many of you use external fixators in hand surgery? Yes. What fixator do you use? Yes? Okay, okay. So I think most of you are sort of dealing with open fractures all the time, so it is a good idea to use X-fixes in your armamentarium. Maybe you can ask Sanjay sir or whoever your HOD is to start getting this in your inventory. There are a lot of locally available good quality external fixators, and they will make a huge difference to your outcome in skeletal stabilization. It's a lifesaver. So we should know the basic principles of use. Okay. So what exactly is an external fixator? It is just a device which is placed outside the skin. So it is an external fixator, not an internal fixation like a plate or a nail. It is used to stabilize bone fragments, and pins or wires are used connected to bars, and these operate on the principle of relative stability, which means plate will give you absolute stability. There is no movement of the fracture. Here there will be a little bit of micro motion, but that is within the normal limits, and that amount of micro motion will mean that there will be some callus formation or bone formation, new bone formation at the fracture site. So that kind of fixation is called a relative stability. Like an IM nail. IM nail is also giving you callus formation, but anatomical rigid plate fixation, a compression plate will give you absolute stability, where there will be no movement at the fracture site and there will be healing by primary intention. There will be no external callus, there will be only internal callus. So external fixator operates on principle of relative stability. So if you want more stiffness or more stability, how do you increase the stability in an X-fix? You can increase the number of pins. So here you see you have 2 pins. If I put a third pin and a third clamp, I can increase. So instead of 2 up and 2 down, I can put 3 pins below and 3 pins above. By increasing the number of pins, I can add more stability. By using thicker pins or thicker K wires, instead of 1 millimeter, I use a 1.2 millimeter or 1.5 millimeter if the size of the bone permits. Then I'm adding more stability. I can add another rod like this, like another rod. So this is called a connecting rod. And I can shift the rod closer to the bone, closer to the skin. So by doing these things, I can increase the stability of the fixation. So what are the advantages when you have a wound like this? External fixation causes minimal damage to the blood supply. The fixation of the bone is external to the skin. So minimum damage to soft tissues. You can debride the wound. You can do your soft tissue cover also. But it is always, if you are working with an orthopedic surgeon, the orthopedic surgeon should consult his plastic colleague where to place the pin so that it does not affect any future plastic procedure, a flap, advancement flap, local rotation flap. If you have put your pin right where your plastic surgeon colleague is going to do the flap, he is going to come and curse you, ye kya kar diya, tumne mera perforator bigad diya. So that's what's going to happen. So the fixation is away from the site of injury, and then theoretically that reduces the infection risk. There are some disadvantages. If you are going with this Taj Mahal constructed on your wrist, it is restricting your joint motion, and it's also very cumbersome. There is a risk of pin track infection always, and walking around with this construct is, wearing clothes, etc., change of clothes, it's going to be very difficult for the duration of the fixator. And then it is going to give you inadequate stability for certain fractures. Okay, despite all this elaborate construct, the bone stability might not be enough. So what are the indications? So mainly for open fractures. You can use it for closed fractures also where there is some soft tissue compromise. You can use it for periarticular fractures, very useful for additional stability. Just a K-wire will not do. You add an external fixator for that. And then you can use it for deformity correction. You have done a contracture release to stretch out a contracture after burns, everything. You can use it, it's very useful. The complications as usual, again, neurovascular injury. See, on the ulnar side, you have the ulnar nerve. On the radial side, you have the superficial branch of the radial nerve in the wrist and its branches. The cutaneous nerves are always there, so you have to be careful of the local neurovascular structures. You can get pin track loosening or joint stiffness. If you have kept them on for a very long time, the joint is not mobilized, the joint can get stiff. And especially if you have impaled the capsule and the ligament and the collateral ligaments, it is going to give you problems. You can get joint stiffness, you can get malunion, non-union, especially in a distal radius fracture treated by X-Fix. There will be some inherent collapse after the fixator has been removed. And if you are using ligamentotaxis, some people very overzealously tighten and distract. Let me get as much of ligamentotaxis as possible. I will get every fragment to be aligned, hairline reduction. And in the process, they are stretching the joint so much, you can get CRPS as a result. So, basic classification, you can have a uniplanar. So, you have all the fixation in one plane. This is called a uniplanar fixator. If the fixator is in two planes, it's a biplanar fixator. Or you can have something called a ring fixator. It's also called the Elizara fixator after the person who first invented it, Professor Elizara from Kurgan, Siberia. So these ring fixators have various reconstructive surgery. You can do bone transport, bone lengthening, a lot of things. But because of the cumbersome nature, mostly we don't use it in the upper limb. The use is more in the lower limb. I'm only sticking to those which we use commonly in the hand. Now if you use with respect to distal radius, this can be joint spanning or a bridging when the fixator is in the metacarpal and the distal radius here, it is crossing the wrist joint, so it is a joint spanning or a bridging fixator. If you have all the pins on one side of the bone not crossing the joint, it is called a non-bridging fixator. Margaret McQueen from Edinburgh has a large series of distal radius fracture treated with non-bridging X-Fix. You can have a static fixator like this one. You can have a dynamic one where the PIP joint, this is a Suzuki frame. You can see the patient can move the finger and the joint. So that is a dynamic fixator, yeah. The aim of use is to hold the fracture in alignment. It can be either a temporary or a definitive treatment modality. It allows for the soft tissue to healing or maybe a secondary procedure to be done in terms of skin coverage. It also allows for deformity correction. So in the next few slides, I'm going to talk very little about JESS, Suzuki and some improvised fixators, okay? So do you know what JESS stands for, anybody? JESS? And do you know who Professor Joshi was? Okay, very good. So that was my thesis, and when I was in MS, he had about 30 years ago. Okay, K-wire and link-based external stabilizing system developed by Professor B.B. Joshi. It was a very legendary, innovative thinking, way ahead of his time. We have an oration in the Indian Society of the Hand in his honor, which called the Professor B.B. Joshi oration. So every year in the Indian Hand Society, to commemorate him, in his memory we have an innovation. Profound impact on the treatment of hand injuries. He used to work in Bombay in the dock area, and he used to, I have met him, I've had the privilege of meeting him, and after I had done my thesis, he had come to Calcutta for a visit to visit my boss, Dr. Sailen Bhattacharya. They were very good friends. So he showed me his entire collection of hand injuries. He used to say he used to work in an industrial area. Dr. Sudhir Warrior and Dr. Nandulad were working with him at that time. So they used to see a lot of industrial accidents, and there were no proper fixators. And those people are laborer class people, no money, with local anesthesia and a little bit of jugaad technique. This is how he saw an electrical pin, what this plug thing. You've seen the wires go. From that, he got the idea of that, you've seen an electric plug when you remove that brass pin which is inside a plug. So you see the screw which goes in like that. From that, he got the idea of a Jess clamp. And that's how he built upon the system. This is the Joshi's external stabilizing system. Very fascinating. You have to read the book sometime. Yes, sir. Yes, sir. Very much, sir. Sir, our generation will remember we have interacted with this. Yes, yes. So started with the management of industrial hand injuries. So what it is it looks, some of the inventory is like this. You have L rods and Z rods and these connecting rods and these clamps. And basically rest of it is all K wires mostly. So it's a minimally invasive technique. It is very simple, modular and lightweight, and works on the process of on the principle of ligamentotaxis and segmental fixation. It is very useful in trauma and reconstructive surgery. Do you know what this position of the hand is? What is this called? Is this functional or the safe position? Functional position is this. Safe position is this. What is the difference? When I'm doing anything, most of the thing, my PIP joint is flexed. I cannot work. This cannot be a functioning hand. But this is a position of safe immobilization. It is called the James position or the Edinburgh position or the POSI, position of safe immobilization. So James position or Edinburgh position like this, okay? So the idea is any sort of crush injury or anything, when you get the bones aligned and put the hand in a functional position, rehabilitation later on, any reconstruction, a secondary surgery, the outcome will be far superior, okay? All you need to do is just put everything back like this. And then trust nature. So this is some of the inventory. You see this connecting rods, K-wires, clamps, Allen key. Very simple, very cheap. 2,000-3,000 rupees, 4,000 rupees. This is what we are talking about, as opposed to 50,000 for a locking plate. Yeah. So, and in a sawbone, it will look like this. You put the position with these clamps. You can, depending upon where the fracture is, you can stabilize any bone with this fixator. Yeah. This is the Jess assembly. So if you have a hand like this with multiple crush fracture, you don't know what to do. Soft tissue is your domain. You know how to deal with it better than I do. But skeletally, how will you stabilize that so that you can do your soft tissue position? Use a Jess fixator. Put it like this. Yeah. And this gives you ample opportunity to do your soft tissue reconstruction, maintaining the hand in the position of safe immobilization. Okay. So these are other indications of the Jess. These are distractors. So this was an old fracture which I had done. I do this technique a lot. A lot of people do hemi-hammered reconstructions and everything. When the subluxation is not much, I do a distraction arthrodiastasis. So I stretch the joint a little bit and put a extension block wire, and then after keeping it in static mode, I commence mobilization. We do get good results as a result. This is another fixator, open wound here. This is another example of a Joshi's fixator. This is not my case, someone else's case. I just borrowed it. So a fixator here. Let's come to the next one, which is a Suzuki frame. Yeah, Suzuki frame. How is it different from the previous fixators you have seen? It is a, what kind of fixator is it? It's a dynamic assembly. Okay. So we're going to have a workshop. So dorsal PIP fracture dislocation is the ideal location, ideal indication. If you get a true lateral view, which has been told today by Dr. Ansari, if there's a finger injury, Never miss it. You will get an oblique view, you will miss it. So isolated finger injury, get a true lateral view like this. If possible with 150% zoom magnification, you will not miss injury. You don't need a CT scan. Just an X-ray with magnification will pick up injuries like this. So what do you do? First part is the reduction. So you will reduce it. And how will you maintain the reduction? Here you can use an extension block pin. You can do that. You can pass another small K-wire through this and keep it reduced only with K-wire. But that is not a static, that is a static assembly. It is not. So you will get a good articular congruity, but there will be a lot of rehab needed in terms of physio to overcome stiffness. So Suzuki, you can start mobilization while maintaining the joint congruity straight away. So this comes to us frequently encountered, many treatment modalities. Suzuki is a very popular choice. And this is the paper, the original paper 1994, pin and rubber band traction system. It was published in JHS in 1994 by Suzuki et al. So this is how it looks like grossly. It's a pin and rubber band traction system used to treat the PIP, dorsal PIP fracture dislocations mostly. It's a dynamic fixator. It requires minimum inventory. Can be done under local anesthesia and a ring block. So what do we do? First step, we pass a transverse K-wire. Then we put a 90-degree bend. So these are 1.2 K wires and the wire is passed through the head of the P1. And then you put 190-degree bend and 190 bend. So once you have put the two bends, it should look like this. One big U like this, and similarly you have passed a transverse K-wire through the head of the P2. So through P1 transverse K-wire, P2 transverse K-wire, two long transverse K-wire, then you bend both of them into two U's, one smaller U here and one bigger U here. So once you have got this construct, then we start putting the hooks. Then you have to bend it in the form of a hook. So cut it and bend it. So this gap should be at least about half a centimeter. Here, this gap, and this gap between this hook and this hook should be at least 2.5 centimeter to allow the placement of rubber bands here. And this is the rubber band traction. So between this hook and this hook, so this will apply a distraction at this. So what happens when you do this? This is how it looks like. The joint is reduced. Sometimes you use a transverse K-wire which is passed a little bit volar in the middle of the P2 to prevent the dorsal subluxation. This is an additional optional wire. So basically one large U, one smaller U with hooks at the end, and you have rubber bands connecting like it, and it looks like this. And this is a dynamic assembly like I have shown earlier. Okay, so how are we doing for time? Do we have 5 minutes more? I can show you another. Okay, so I will show you a modification of that. So what did you find problematic? So when I started doing Suzuki frame, I found that making the hooks was the most cumbersome. Just getting the hooks exactly 2.5 centimeter. One hook is longer, one hook is shorter. 2 millimeters long. If I put the rubber bands on both sides, one side is pulling more, one side is pulling less. So already you have trouble passing a 9-inch K-wire in the dead center. It has to be parallel to each other. Otherwise the forces are unequal on both sides of the joint. On top of that, if the hooks are at unequal levels, even by 1 or 2 millimeters, it is going to give you unequal traction on both limbs. So that is an inherent problem of the Suzuki frame. So during COVID, we had no patients. We were sitting with saw bones in the department, no patients. So we were thinking what to do. That is why our brain started working. Let us do something different. So we were playing around with K-wires, trying to do this Suzuki frame. Then we thought we had some link joints from a Jess set also. We thought, let's see how we can modify it. So we came up with an idea called the Kolkata frame, which is a modification of the Suzuki frame. I'm just throwing it out for you. Feel free to reject it, criticize it, use it, adopt it. It's your choice. But I'm just giving you an alternative. By no means it is established. So we presented it in ASSH meeting in Chicago, and it got good reviews. So based on that, I'm having the courage to present it in front of you. Otherwise, I've never presented my own work anywhere. So basically what you do, you take the two K-wires and bend it into two U's. So this is a pre-bent U, okay? So you don't have to modify and make hooks or anything. And it's a pre-constructed frame. You have only two K-wires, two hooks, two U's, and 4 clamps from the Jess set. These are mini clamps. So what we do are the steps. Drilling a transverse K-wire which is only 2 or 3 inches is easy instead of a 9-inch K-wire which has to go center, because 9-inch K-wire will wobble. A 3-inch K-wire is a single pass. You pass through the P1 head. Similarly, you do another one. Okay, so you have 2 parallel K-wires, short ones. Not simple. Anybody can do under C-arm. That's your assembly done. That's all you need to do. Fracture is reduced by pushing it. So maintaining the frame, what do? You take 2 rubber gloves and cut off the fingers and make rubber bands from the rubber gloves, surgical gloves, yeah. So larger U, smaller U, 2 rubber bands from the gloves, surgical gloves. And this is the Jess clamp which looks like that, and this is the Allen key which sits into that. So what do we do next? We do the distal fixation. We just apply this clamp on both sides, and the smaller U we clamp it to the transverse K wire which is through the head of the P2. We still have the longer one here. We flip it and then attach it here with 2 clamps here. Then it becomes something like this. So you have 2 transverse short K wires. You have a longer U. You have 4 clamps holding it here. And this, by sliding this up and down, you can vary the amount of traction. So it gives you more modularity in terms of the amount of traction, because you can sometimes think I'm over distracting it, I need to loosen the traction a bit more. Or if you think it is under distracted, I want to stretch it a bit more. This clamp you just have to loosen and slide it, you can get that modularity. Every time, because it's a pre-constructed frame, it is going to give you equal traction on both sides. There is no fear of giving more traction on one side, less traction on one side, and your fracture is going to angulate this way, that way. No, it is going to be dead straight every time. It's very simple. Takes 10 minutes to do. This is how it looks like, and this is how it looks like, and you can see it's a dynamic assembly as well. Okay, so this is a 3-month follow-up. Patient was a dentist, no pressure. I seem to get up all doctor patients, I don't know why, but anyway, so that's the thing. So we went up with a good result. So then Indian brain is very famous for jugaad. So I'm going to show you another way where fragments are very small. You get away with improvised plastic needle cap fixators. This has also been published. So this is a condylar fracture. You can fix it with K-wires like I have showed you earlier. But then simple K-wires, you're always worried about losing the reduction. So this is just apart from the pins which you put in, use an external fixator. This is just 2 transverse K-wires passed through a sterile needle cap. 18-inch needle, take off the cap, and that's how it looks like. That is the AP view, lateral view. Very simple, and because the bone fragment is light, you can put a metallic distractor, but it's so heavy, it's just going to pull your finger down, and the patient has to walk for 3 weeks with that on. It's very difficult. These are very simple and easy to do. Look at this fracture here. Another fracture here. Fixator. Did the routine K-wire fixation, but supplemented it with another sort of external fixator with a needle cap. That is the reduction. One more. Very communicated. This guy plays golf with me, so you can see the pressure. If he can't hit a good shot, the blame is going to come on me. He came with this nasty injury. It's like a peel-on fracture. What do? I tried the best I could. I'm not going to put a plate or anything here. Then he will be cursing me all his life. So again, very simple method, K-wire. Managed to get this. He's still playing golf and he's not swearing at me anymore. So it's good. I must have done something good. So in summary, it's a very useful tool in the hand surgeon's armamentarium, external fixator. Static fixator can be used to allow the fracture in safe position. You can immobilize, like the Jess. Jess is an indigenous versatile fixator. Dynamic fixator like Suzuki frame. In dorsal PIP fracture dislocations, they are very useful. Improvised fixators are very lightweight and useful when you are dealing with small bones as an additional fixation. But whatever fixator you use, the most important thing is you have to be very meticulous about the technique. Okay? Thank you. We're doing a model. You want to see the Suzuki here? I'll show you how to do it and then we can do the model. I'll show you. Give me a minute.
Can I add one thing, sir?
Sure.
Most of the finger replantations or in the wrist, where you need to have a shortening of the bone, and in open fractures, it usually happens. So what about the applications of the external fixator?
External
Because
fixator.
most of the orthopedic surgeons, they have a conception to put external fixator.
Yes.
In these cases,
Yes.
which make a hindrance to the plastic surgeon.
Yes. So that is the thing, sir. It is always, replant surgery is always teamwork. So if I had to put an external fixator, I would never dream of doing anything. Even forget a replant, sir. Even open wound. If I know how to do the soft tissue coverage myself, it's fine. Otherwise, I will get my plastic surgery on day 1 itself and say, what is your procedure? What do you plan? where do you want me to place my pins in such a way so that it's not going to impede any future reconstructive work. That is standard in multidisciplinary team approach. That's right. So we will always work in consultation with the plastic. In fact, it is very good to have the plastic surgeon with you at the time of initial debridement, because they will do a better job of debriding than we will do.
And it
Because,
happens in public hospitals.
Yes.
Corporate don't have this concept.
yes.
Sir, you had shown a finger distractor.
Yes.
Can you tell the indication in which you used it and what's your rate with them in protocol?
In the interest of time, I will do it at lunch break. I'll show you my whole series and I'll show you my technique also. But you had another question about the oblique fracture. So both of you, maybe I will show you both of, maybe in the lunch break or something like that, huh? Because we have to get through a lot and we're already running a little bit late. So is it coming? I'm not seeing this on the video. It's here, okay. Maybe this. No, this is okay. It's working okay. The whole screen has gone blank. Duplicate. Now it's okay. Okay. So this is a very short 4-minute video. We will see this and you can go and do it there. Okay. So this is audio, but I will just give you. This is a 12-day-old PIP fracture dislocation. You can see the fracture is here. Okay. So first you will manually reduce it. The first step is passing a transverse K wire. This is what I was having the problem with, the transverse K wire, which is very long, which has to be very parallel to the joint. It's quite difficult. It needs a little bit of skill. So you've seen that the K wire is transverse parallel to the joint in the center of the head of the proximal phalanx. So bending first of the wires. Then you can put a bend at 90 degrees to form that loop. As you can see, it's a little bit of a fiddly process with benders. That is what gives us the idea of, and it has to be equal on both sides. Then once you have bent it, this is the second K wire. Every time you have to advance it little by little. If you don't have a pin collet, it's a problem. So, but then this is your second trans wire to the head of the P2. Slowly you are advancing it. Equal on both sides, then you form the second U. So two parallel K wires, you bend it to make the second U. Bending the second of the wires to the distal part of the middle phalanx here. And do it symmetrically on the opposite side as well in the same plane. So the gap should be equal on both sides. Close to the bone. Once this has been achieved, you have to adjust so that you get a perfect 90-degree bend. So some fine tuning is required here with the nose flat. Then once that is done, it should look like this. Okay. Then you start making the hooks. So you made a small hook. So this is a hook. This is a hook. So then you have to put another hook here like this. So one bend here, one bend. Once it's finished, it looks like this. Then once it looks like this, you add the rubber bands. Once the rubber bands are added, this whole assembly is now dynamic. You can add another transverse K wire, a little bit volar, and this goes on top of this, and you can bend it like this, so it looks like this. So it prevents the dorsal subluxation. This additional transverse K wire is optional. This is the complete assembly. This is how it looks like on lateral view. TP view, joint, and you check that it is stable. You move it on the C-arm and check the stability, that it is not displacing. Okay, so that's how the Suzuki frame is. We will go and do it on the bone model. Mobilize. You have at least 3 weeks, between 3 and 4 weeks, depending upon the fact. Yeah, the patient keeps on moving this. So that's how you prevent the stiffness. The collaterals are stretched and you keep moving. So basically after removal, you don't hardly need much physiotherapy. The patient is already able to bend it. If you put a static fixator, then you have to spend almost an equal amount of time to regain the PIP flexion. We got about 20 minutes. Let's go and do it on the bone model now. It has to be at least 2.5 centimeter as per the original paper by Suzuki himself. The traction has to be adequate. So at least 2.5 centimeter. It has been shown that if it's not 2.5 centimeter and the recommended thing is not a glove, you have dental rubber bands. 2.5 has been shown cases that should be the optimum. I have seen cases, I think Dr. Paraglad and he presented a case where there was over distraction, there was a collateral ligament injury which was unrecognized. And as a disastrous complication, they had a rupture of the collateral ligament with the joint bending too much on one side. So the frame which I showed, that was the beauty. After 2 days, you can get a check X-ray and see amount of traction. If you want, you can just use the LNP to reduce it or increase it as per requirement. That is why I showed you the modification.
Yes, sir.
Can we take questions as we go? Otherwise, we are holding everybody back from the workshop. I am given to believe the director is going to come for the inauguration and we don't want to keep him waiting. Everybody has a long KY, 9-inch KY, everybody has. You know how to use this particular back with this? So I want you to drill one transverse wire through this, another transfer wire through this. Okay, that's your exercise. This is your thing. Do it very carefully. I will show you. So basically, this is forward, this is reverse. Forward, reverse. So you can control the speed. Press slow. Slow, fast. This is a control. This is not cannulated, so it will only go partially. So there is no chuck key. Just check it is in the center. And then once you check here, without hurting anyone, just lift it. This is ready for use. So for the purpose of this exercise, let us take the radial finger because this is very stiff, it's not moving. Bring one transverse wire here, one transverse wire here. So transverse, and then we will bend it, start, and then make the U, and then we will come back. So
pressurize it, no? Then it will bend and it will go in the wrong direction. So you have to be very careful when you are having a long cable. See? So when you have a long cable, you have to be very careful.
To be sharp wire.
It's not a practical thing, it will not work like that.
Always what you do is not calculate it only for half bend. Industrial drill actually you are using it as exercise. Once you have it here every time, just check safely. I mean, don't injure anybody, be careful. Let's see you in 5 minutes.
తీసుకోండి దాన్ని ఫోన్ చేసి పెట్టండి త్రూ
फॉरवर्ड में है ना
Forward में.
వెళ్ళండి
Back.
you have to go make a U na
Yeah. Reverse. Yeah. We have to make a U. But no, I was reversing it deliberately. So because
ఎందుకంటే ఇక్కడ వరకు దీస్ ఆర్ ఆఫ్ ఈక్వల్ లెన్స్ ఉన్నాయి
centimeter. This will be 1 centimeter away, this will be 0.5 centimeter. Yeah, bend 90 degree, yeah.
इसको रोटेट कर देते हैं साइड साइड को ले दे और तो
He didn't render that one. Actually, it is rendering possible. This is nice.
have a lot of evidence if I just tell you about all those fractures and critical part. But it's a workshop, let us go for the practical thing. Okay. So for going for any practical activity, you should know the instrumentation and the exact technique on the sawbone model. So this is the video which I prepared as a team. You may be able to see all the final steps here.
Welcome everybody. This is video of lens to fixation. I'm Dr. Khalid. I'm Professor of Orthopedics in Colleges of Medical Sciences, New Delhi, and we don't have any guidelines for you. And this video is only and only for education purpose. So I welcome my undergraduate Dr. Pankaj. He will be helping me because all these surgeries need some good assistance. Okay, welcome Dr. Pankaj. Are you ready to help me? So this video will be in 2 steps. First, I will let you know about all the instruments here, what are required. And in the second step, we will be demonstrating you how to use those instruments for a perfect leg fixation. Okay? Let us start with step 1. So this is some of what we have created a short of the infraction, the elements on here, the middle figure, and this is a long of the infraction. So this technique can be utilized either for short oblique or for long oblique or for spinal fractures. Okay, so this model will be used here. We will first fix the fracture prodigiously with the help of reduction clamp. So this is the most common reduction clamp we used. It has got 4 pounds, but don't use it as a tiger's claw. Don't put too much pressure, otherwise you will just make a committed fracture. So use it very carefully. Next is this reduction clamp. This is very useful, especially for short oblique or for long oblique fractures. One side it has UFC, there is 1 point of fixation. The other side you have 4 points of fixation. And generally this is commonly used in two settings of long oblique fractures. So you have got 2 fixation points there, and 2 fixation points there. So it is essential to have all fixation clamps. Sometimes you can use 1 or 2, maybe sometimes you can fit very easily, but at least you should have 3 reduction clamps. After holding the fracture with the help of reduction clamp, we will provisionally fix it with the help of these K-wires. So 1 or 2 K-wires can be used for provisional fixation of the fracture. Next step we will be using these screw drills. So for 1.5 mm screw, we require 1.5 mm drill as a pallet foot or a gliding foot. And all contacts is drilled with the help of 1.1 mm drill. So if you see here, you have 2 markings, 2 green circles. This is the 1.5 mm drill, and it has got 1 circle. This is for 1.1 mm drill. So what will remember?
So here we will be using 2 mm screw. So you will have 2 mm drill and 1.5 mm drill. And the color coding will be red. 1 red drill
or 2 drag ring. 2 drag ring means 2 mm and 1 drag ring means 1.5 mm. Okay?
This is basic. You have this drill guide, and one end you see these are drill guide two. One of the drill guide is having one circle. This is for 1.1 mm drill guide. The other guide is having two circles. So that's for 1.5 mm drill. This is your first coding. This is the hand line. We just apply the thing like this, and then can use the drill bit like this. Okay, so it's very simple. You can use the same wood or something. This is apply the one, and can use 1.1 mm drill bit. So this is very simple technique we use it. Next step will be for measuring the length of the screw. We will be using this depth gauge. So when you measure the length of the screw, always take the longest length possible, not the shorter one. So you should have a high particle surface of the screw. And then how to take out the screw? You see, this is the screwdriver. How to hold it? You hold it with your palm and with 3 fingers. Okay, so with your hand, you give the direction, and with the finger, you just rotate it. So we all know with previous knowledge, a screw is a device which converts potential forces into longitudinal forces. So how to take the screw? You see, this is the screw box. There, suppose if I am going to use a 16 mm screw, we just put the screwdriver into the screw head and then pull it. This is how you can take the screw from the screw box. Okay, now we will go for the practical demonstration. So we have reduced the practical liquid. I am going to hold it with the right of this central clamp like this. So this is how it will look like. These might be comparable to vector like not like this, or maybe something like this. Okay, so it's just try. So you have to do it with soft hand. Do not try to push.
Like to give you one practical tip actually. If you don't want to use a screw, then you can use these K wires and leave it as such. You can mobilize as a pain guided protocol. The fixation is stable enough physiologically that these K wires can be utilized as a primary tool also. Okay. So the gliding hole is equal to the thread diameter that I have told you initially. So the screw will glide there. So usually the diameter of the threaded hole is the core diameter of the screw. So this is very important. You will take the question in the last.
The principle of lag fixation is to achieve intermittent decompression by having the screw threading gauge holding the fast cortex, allowing the head of the screw to compress the bone against itself as it is tightened. So you see these are self-threading screws. You see this screw, 31 left should be out of the fast cortex. Okay. For aligned screw, use composite. These are going to if you use composite, you will weaken the breaker. And similarly, use composite and will replace it with screw. The same steps will be repeated here. Anybody who wants to screws, obviously provide rotating stability. If you just use one screw, it will rotate on that screw.
This is very important. The first question then came to us was the screw during the wire during replantation surgery. So use 2K wires.
All of you know what near cortex is, na? And far cortex. Yeah? So this side of the fracture, we over drilling it with a larger diameter drill bit. On that side of the fracture, it is a thinner diameter drill.
So indication, I told you with the degree. The first indications are very simple. To TU is technique for transverse fractures or for dominant fractures or when you see a particular fracture. Okay. Now, for far cortex again, you go and again. Yes. You see, it comes out to be 17 again. That was 17 and it is 4. So just device to the length of these screws. You see, I'm just holding it at direction with my wrist and elbow and force a little bit with my fingers also. You see, I'm just rotating it and the screw is going by itself with engaging the fast cortex. Now I have that purchase feeding at the ground. Something like that. Now I will remove the reduction clamp. You see. And the final fracture given to each screw half a turn each. So this is how you will do take your settings. Okay. So these are the perfect screw, 2 legs screw for the fracture. So this is the whole model. It's very easy. In light patients, you will have the effect of soft tissues also. It's easier in light tissues than in soft tissue. Thank you everybody.
So few practical tips if you are using in the phalanx actually. The screw head should not tether the tendon. It should be beneath the extensor apparatus. You give a little bit of incision or use the safe zones actually. Even there's no, when you see the finger, there's no safe zone. There are some tendinous attachment or ligaments out there. So give a little bit 1 centimeter or less than that longitudinal split in the extensor apparatus, so that the screw goes directly to the bone. If you are using these screws and just teasing the tendon slip, so that will lead to further stiffness. Just one part is remaining. I promised you initially I will ask you one MCQ. This is MCQ generation. So the MCQ right now is, which fracture has got highest tendency of extensor tendon adhesions? The answers remains the same. Option A, metacarpal fracture. Option B, P1 means proximal phalanx. Option C, P2. Or option D, P1. Middle phalanx, proximal phalanx, distal phalanx, or metacarpal? Which? It's P1, proximal phalanx. So these fractures are very, very notorious. If you use screws, plates, I don't use plates here, it's very difficult. And even these screws, it's very tricky. If you have these fractures, just think about some tendon adhesions will happen out there in the proximal phalanx. Okay, thank you. Yes. Sir, exactly. So first of all, you see what's the glabrous border in the finger or in the hand. You see this white skin and the brown skin, the junction out there. So you just flex it. Okay. So screws or any incision should be at the glabrous border or dorsal to that, not below that. Never ever go below that.
Just do it on your finger. Just see this where the skin margin ends. No? This is the color change. So mark one point here, mark the highest point here. So 2 points. If you straighten it, you get 2 points. You connect it. That is the line. Glabrous. And then the dark skin dorsally, you stay on that midaxial line or slightly dorsal to it. Polar to it is the dangerous neurovascular.
It's very, very important practically. Otherwise, you will have complications. What's next? Yes, please. That can be done, but that will be a little bit high risk behavior, I will say. You will displace the fracture or make it comminuted. So do it safely. Any other thing?
Any questions?
Yes, I will ask a few questions from them itself. I have so many MCQs.
Either they ask questions or we ask them questions.
So in the whole body, if you say you have lots of joints, knee, ankle, hip, shoulder, elbow, wrist, then joints in hand. Tell me which two joints, not one joint, which has got highest propensity for stiffness. Lower limb, have you ever seen stiff knee? That happens because of quadriceps contracture. Tibial plateau, all those injuries rarely get stiff. You will have movement in the knee. So two joints you always remember. In the priority, first is PIP. And second is your elbow. So if you see these injuries in the PIP in hand, just think about to mobilize and stable fixation, whether with wires or Suzuki or anything you want, but you have to mobilize. Okay? So I hope you will not forget it, the stiffness, the extensor part, and the rotation part. I tell my residents, the what is notorious and what is common. Notorious means you will miss it. Why you will miss it? Because you have not seen it. So I hope once you go back to your practice, you see metacarpal fracture, what you will look for? Rotation to knee over, I think. Okay? And practically also, 3 ways of looking the rotation. Obviously, the seizuring, the most common. The tenodesis effect, the patient is not helping, or you just ask him to move the opposite hand like this, flex, extend, this you do yourself. You extend your wrist, your finger will automatically bend. So ask him to opposite side, then the injured side. He will move the wrist because injury is somewhere here. You will see the rotation. And the third point, you see it tangentially the nail beds. And you see these are forming parallel lines, the tangential lines out there. These are 3 ways of looking for rotation. And surgery wise, the one maneuver, when patient is under GA or under block, that's another way of looking the rotation in the phalanx or the metacarpal. And practical purpose for me, for sir also, most common medium or use is in phalanx, we use wires. And for metacarpals, maybe 30% plates, 70% again wires.
Mostly wires because it is stable. Unless there's combination of butterfly fragment, then we will tend to use plates. Multiple metacarpals, unstable, then we might use plates. But mostly we try and get away with wires.
Exactly. Removable. One term is my patient should be implant free. So I don't want my patients to live with the implant actually. That is the reason we prefer wires. Yes. For if you see a little wider thing, what's happening later on. If I use it in the metacarpal itself, the leg screws, these are going to act as a stress riser whole life of the patient. So I don't use it in the metacarpals. I use it in short oblique or long oblique fractures in the phalanx. Even again, most of the patients I use the wires, but leg screws is a commonly used technique. I use that too also. I have more than 10, 15 years of follow-up. They are doing good. Yes, that's a very good question actually. Use, the sir has just given the initial line, proper treatment and don't mobilize it. Improper treatment and don't mobilize it. So that's the worst case scenario. So now the term has come up with a pain guided protocol. What is pain guided protocol? You apply the wires and ask the patient to move when he has or she has started having pain. So he or she has to go just below that. For example, this is an injured hand and I fix the phalanx with the help of wires. So I ask the patient to move it. He is saying now he has pain. So I have to tell them, then go up to that point, just go below that. So he is able to mobilize that only. That's the only recommended range of motion. That's called pain guided protocol. That's another concept, sir will tell you.
So the thing is, fracture healing, you have to understand, goes through 4 phases. Like normally for a long bone, phase of inflammation is 7-10 days. Then we have that soft callus formation, which is about 3 to 6 weeks, and then from 6 weeks you have hard callus, and then the healing is from 6 weeks to 2 years. It can take more days. So in hand, you are talking about balance has to be perfect, the timing. You have to get the fracture to heal sufficiently so that you have to get the mobilization at the correct time. If you leave it too long, you will get a good looking X-ray but a stiff finger. If you take it off too often, then the deforming forces before depends upon the something which you have to do. It's about your type of fracture and also the personality because that is the fracture which takes into account plus you have to forget, you don't forget that there is a patient and everyone's brain may chemical loop that happens differently. You know, some people are very over. If you have a Fauji guy, he will be doing like this, he does this, and some, you know, they get darling types who will be the finger and they will not be moving it and doing it. fracture is different. But in a finger, you will not see a proper bone callus for 3 months. So for 3 months, you will still see the fracture line. It doesn't mean that you keep the films for that long. You will get feedback into it. But if you don't mobilize sufficiently early, you get stiff. 3 to 4 weeks is maximum. Unless it's like a perivelar dislocation or ligamentous injury where we sometimes leave it for 6 weeks, 8 weeks. Correct?
Exactly. And in textbook, you will learn two words. One is radiological healing, other is physiological healing. So in hand fractures and foot fractures, actually, radiological healing appears much later on. So physiological healing means, one, it becomes pain-free. It takes 3 to 4 weeks, not more than that.
So you recommend, sir, that after we put the KYs, not domicable, but we cross KYs or whatever, after that we start the
Pain-guided protocol,
immediately,
yeah,
like within 1 to 2 weeks. And then we remove the thing within
3 to 4 weeks. For example, if there's a middle phalanx fracture, condylar fracture, 3 weeks is enough. Or if you are seeing a diaphyseal fracture, then 4 weeks is enough.
And can we apply to revascular with badly communicated fractures?
C1 means
Replantations and revascularizations or badly communicated fractures of the phalanges. Can we apply the same like
regarding mobilization.
mobilization and removal of
It depends. Actually, once you see the classical textbook teaching, what's that? It says if there's a compound injury or you have made a closed fracture into a open fracture. So the healing takes double the time. So if it was 3 weeks, then it becomes 6 weeks. So that is the difference. For the planted finger, I think that will take much longer time, maybe 4 to 6 weeks rather than 3 to 4 weeks.
I think in 100% of the cases, we have to shuttle the bone, get the vascular
Exactly.
operation without tension. So let it be in the hand or in the
Again,
so in that case, we have to strip off the little periosteum from both sides.
sir, there is one MCQ that I wanted to ask them, but so I have to ask them right now.
So I think you were rightly told that it takes a little more longer. Yes.
Longer time. So the next MCQ is if you keep the wires out of the skin or if you keep the wires within the skin, you don't bend it, you bend flush with the skin and the wire goes inside the skin. So what is the infection rate? 5%, 10%, 15%, 20%, 30%. Any idea? Because infections are happening with K wires. So it's different in both the cases. If you keep it flush with the skin or beneath the skin, the infection rate is 5%. If you keep it out of the skin, it comes to be 15%. So it depends upon you where you are dealing with your conditions. Most of the times, if we keep out of the skin for mallet injuries, and so we keep beneath the skin. If the patient is non-compliant, we take it beneath the skin. And if patient is compliant, and then we give out of the skin and keep the patient antibiotics on maybe for 7 days or 10 days.
So mallet finger, sometimes if I do extension block pinning, I might remove the K wires at 4 weeks, but I substitute this for a splint for another 2 weeks. You don't give the patient mobilization because it requires 6 weeks of mobilization for the extensive finger.
So yes, please.
For head fractures of proximal or middle phalanx, do you prefer a black screw rather than a K-wire? Because when we try to mobilize the patient, the pin always irritates the skin and the patient keeps on telling pain.
Exactly. So it depends upon the fragment size. If it's only the condyle, there is no metaphyseal fragment, then just wire is enough because screw will be a little larger for that fragment. If you have a little bit of metaphyseal fragment with the head, then you use the screw. You can use 2 screws and mobilize the patient as early as possible.
One word of caution which I would use when you're doing small fractures, especially the periarticular, articular head fractures, is often don't go by just an X-ray. either get a X-ray with a lot of magnification or get a CT, because often there are fissure lines or very incomplete fracture lines. And if you are doing an open reduction and you are drilling, and however fine your screw is, that fracture line will progress. And suddenly what is like a two-part fracture is suddenly in 3 pieces, and you don't know how to fix it and you have opened it. Then you start recoursing to good old friend, the K-wires. Then you have done the worst of both worlds. You have opened it, but done an unstable fixation and used it with suboptimal immobilization. Then you put a plaster for 6 weeks. It's a recipe for disaster. So if you are choosing implants for fixation, internal fixation, be very sure that you have enough bone size, screw length is sufficient. Normally there is a dictum about the size of the screw you can use with respect to the fragment. The screw diameter maximum which you can use compared to the fragment. It has to be at least, the fragment has to be 3 times bigger than the screw. So if you're using a 1 millimeter screw, at least it has to be a 3 to 4 millimeter fragment. You can't put a 1 millimeter screw in a 2 millimeter fragment. It's a risky. Get a CT or at least an X-ray with 150% zoom digital X-ray. See the fracture pattern. There are no fissure lines, hidden lines. Always use loop magnifications. And for drilling and all, it's like you take your time, just get your retraction, everything nicely resistant. But look at it from all angles, but drill only once. You can't drill it and say, oh sorry, galti ho gayi, thoda angle change karna. Then you're gone. You lose your purchase. Especially in a small fragment, it's a one shot. You can take in 5 or 6 times, but trigger can be pressed only once.
And just one simple thing actually, in which part of career you are actually. Right now you are learning, then you will start doing independently. So with this sort of information, that physiological strength of two threaded K-wire, 2 screws, 2 non-threaded K-wires, 2 screws lag pattern, which is safest for you? 2 wires. That's the safest. Once you have acquired that expertise, then you can apply all those screws, and so otherwise the chances of error will be much higher with you. So that's the perfect station actually. Sawbones, cadavers, you learn it, do it, then you feel confident, you learn again, read it again, then you do it under some guidance or so, then that will be much safer environment. So sir has just discussed one particular entity. So one question to you again. Once you mobilize, I have seen these physiotherapy protocols, very nice. Somebody has just summarized this whole fracture pattern: stable and displaced, unstable displaced.
A very good afternoon, esteemed guests, distinguished faculty. On behalf of the Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, it is my proud privilege to welcome you all to the inaugural function of our hand fracture fixation workshop. Professor Dr. Bhubaneswar. May you please have a huge round of applause. To our medical superintendent, Professor Dr. Kumar Paridasa. Dr. Mohammed Tahir Ansari. Dr. Ruchi Gupta ma'am, President of APRASO. As is our tradition, we shall begin this session by invoking the blessings of knowledge and wisdom through learning and new beginnings. I now invite our respected dignitaries to come forward for the lighting of the lamp ceremony.
इसको लगा दीजिए, उसमें टाइम लगेगा।
I would like to invite Dr. Chaudhary sir and Ramesh sir to kindly come forward for the lighting of the lamp.
MS sir and seniors Arun Chaudhary sir and Ramesh sir, then dignitaries, the faculties Tahir sir and Varadas sir, and all the delegates who has come from outside and also from Odisha. Welcome to this hand fracture fixation, because as you know, this fracture fixation is very important thing for plastic surgeons. Although we receive these emergency calls, we usually deal with the soft tissue tendons and all those things. Sometimes we forget how to do this bones, and we usually put some K-wires or some stripping or some splinting like that one. So it was come into the mind that so why should we should not treat this improperly and in the new methods of fixation of these bones. So that is why we think of a fracture fixation hands-on model, so that we can go and practice that one. And as discussed with Ravi sir for last 2 months, for hands-on we require minimum 4 to 5 persons. That is why we have put only 30 people only allowed to do this practice. After this, a lot of request has come, but still then we have said no, because proper things should be learned in a proper way. So thank you Ravi sir and Tahir sir for accepting our invitation and making this event happen. And such type of event, I think first time it happens in this area. So at least people can learn, plastic surgery can learn, even the hand surgeons can learn these two things, how to do these things. And at the outset, I am very much thankful to our director sir and MS sir who has given the opportunity to do this type of workshop here, because hands-on workshop is very important nowadays for teaching and training. Even though whatever we are doing in the practical fields, in the emergency, we have to know what to do, what and when to do. So thank you all the delegates who has come from outside, and I hope till now we have got some knowledges, and till the end of the day, I think when you will leave from here, definitely you will get some knowledge how to get and treat these things. Thank you sir, director sir and MS sir for giving us the opportunity to do this. With this I conclude, and I hope it will help you. Thank you.
Thank you, sir. May I now request Professor Dr. Dilip Kumar Paradasa, Medical Superintendent, AIIMS Bhubaneswar, to address the audience and share a few words of encouragement.
Esteemed Director Professor Biswas, dignitaries of the workshop, participants, dear faculty member. Feel very happy as we are discharging the mandate of our institute while organizing any kind of academic events in our institute. It's a learning method for me also. And when I see hand fracture fixation organized by Department of Plastic Surgery, usually when difficult cases come, uh, cut or burn injury, I request Dr. Giri and Dr. Giri, burn and plastic orthopedics, PMR, they form a team. But fracture fixation also plastic, it's learning for me also. So I thank the Department of Burn Plastic Trauma Emergency Orthopedic PMR for organizing such wonderful workshop, hands-on, and I wish all the participants all the best. Thank you so very much.
Thank you for your words of encouragement, sir. Let us now hear from Dr. Ruchi Gupta, ma'am, President APRASO, who will share her insights and extend her support for this academic initiative.
Thank you. First, at the outset, I, on behalf of APRASO, welcome you all. And thank you, sir, for giving the permission to organize this hand and fracture fixation workshop in AIIMS. I congratulate you for a good show. And I thank guest faculty, Dr. Bharadwaj, Dr. Tahir, opportunity to our students to learn from you. It will be a great experience. I can see that a lot of effort is being put, videos have been made, hands-on workshop is being arranged, and I am sure our delegates will make the best out of it. Thank you, sir. Thank you.
Thank you so much, ma'am, for your encouraging words. I would now like to request Dr. Bharadwaj, sir, to say a few words.
I would like to thank Dr. Giri. It's not only an honor but a privilege to be here, and I've been touched by the warm hospitality and that has been extended to me. It's always a pleasure coming to such workshop and sharing the knowledge, and I always feel that learning is a two-way process. Most of my learning has been through various workshops over my career. I have interacted with the delegates and this distinction between faculty delegate, I think it's a continuous process. You never stop learning, and I think with the enthusiasm from all our delegates and all the questions, it has been a very valuable discussion so far, and I'm sure that the rest of the afternoon will also, as it unfolds, be equally enjoyable for all of us. And once again, I'm very grateful for the opportunity. Thank you very much for having me. Thank you.
Thank you so much, sir. May I now request Tahir Ansari, sir, to say a few words, please.
Thank you. Thank you, Dr. Giri. It's a wonderful event, actually. I am really thankful to everybody, the organizing team. They have put so much effort, and these kinds of workshop are the necessity. If you want to practice, one is animation, second is sawbone, third is cadaver, then you go to patients. So this is one step forward, and when I have noticed the residents out here, they are very enthusiastic and they are gaining knowledge, and my good wishes to everybody. And I hope when we leave this conference, you have few vital points, technical tips that you will help your patient, helping the humanity, helping the patients. That's the thing you have become doctor. Okay, so my good wishes to you. Thank you.
Thank you so much, sir. Please join me in welcoming Professor Dr. Ashutosh Biswas, sir, our Honorable Executive Director, to share his thoughts with us.
Good afternoon, everyone. First of all, I would like to thank the Department of the Burn and Plastic Surgery, Dr. Giri and his team for organizing this in association with our state, probably APRASO and ISSH, for having this wonderful workshop for the hand surgeon. And as I understand, probably this is a very important area. The hand is one of the important part of our body, and we need everything should be intact and on fitness for doing all the things. So I would like to also welcome and thank you very much for sparing the valuable time for the guest faculty, Dr. Tahir from Delhi and Dr. Bharadwaj and Dr. Ruchi Gupta and all other faculty members. And our students showing the interest for learning this hand surgery, the fracture and fixation from the various other institutions and AIIMS. I hope you are going to develop the skill for perfect fixation of the hand fracture, how you are going to do. And I understand that also the surgeons, I'm not sure where the domain belongs to which department, orthopedic or surgeon and burn and plastic. But hand surgery, if it is, probably it is, Dr. Giri is saying, this is under plastic, burn and plastic. And really, it is now skill and hand, you will require more finer tuning for apposition of the skin and bones and all. And then it falls under the Department of Burns and Plastic Surgery. So I hope all the aspiring surgeons, the students here would be benefited for learning this training skill for this fracture, the hand fracture and multiple fracture, and you need lot of skill. I was going through this all exhibition, and then lot of instrument equipments are displayed, the finer and all, helping for bone for fixation, and then various other equipment. I need to say technology based, and you need sophisticated instruments sometimes, and you need a setup for that, and then you need a skill for all those who are coming and attending this. Hope this workshop would be beneficial for you. And once again, I would like to thank all the faculty members, guest faculty and all supporting this workshop. Thank you very much. Thank you all.
Thank you, sir, for your words of encouragement. I now request our Honorable Executive Director, sir, to kindly felicitate our esteemed faculty members with a small token of our respect and gratitude. To Dr. Mohammad Tahir Ansari, sir, thank you for gracing us with your presence, sir.
Sir, and Dr. Mohammad Tahir Ansari for their seamless teaching, guidance, and willingness to share invaluable tips and tricks with excellent demonstrations in the enlightening workshop, where one can easily say, I have fixed it all. My heartfelt gratitude to the eminent faculties, Arun sir, Bibhuti sir, Subrajena sir, Ramesh sir, Ruchi ma'am, Dr. Jagannath Sahu sir, and all the faculty who have been present in this workshop. A special mention to all those who have enthusiastically traveled far and wide to participate in this workshop, especially the residents. Heartfelt gratitude to all the faculty members, residents, staffs, and entire plastic surgery team who have made this workshop possible. Special mention to the KLS Martin team for the seamless, smooth arrangement in organizing this workshop, which indeed was an amazing experience overall. Last but not the least, a special and sincere thank you goes to Dr. Sanjay Kumar Giri, HOD of the Plastic Surgery, whose tireless dedication, vision, and meticulous planning and execution have brought this workshop huge success. Thank you, sir, for organizing this much-needed workshop. Thank you all.
As the founder, president of Association of Plastic, Reconstructive and Aesthetic Surgeons of Odisha, I have this opportunity been given by Dr. Giri and his team. So I remember 2004, in the map of India, Odisha was not there in plastic surgery. Dr. Sarma from PGI Chandigarh told Odisha is not doing anything. Now in 25, when we started in 2016 first Burn Conference, that is the National Academy of Burns Conference, it was such a tremendous impact. All over India now, today in 25, Odisha has made its own space in the map of Odisha, what I was talking to the executive director. When just last week, I met the director of All India Institute Delhi, Dr. Srinivas also. He told his students, Dr. Manish Singhal was also there, that Odisha is doing so much in plastic surgery. In fact, the ISSH, that is the Indian Society for Surgery of the Hand, is the only association in India where the plastic and orthopedic surgeons are together. No association in India you find two different faculties, different disciplines are together, and the work is done by a hand surgeon, means the both are hand surgeons, orthopedic and plastic, especially when your replantation is being done. The orthopedic part is done by the orthopedic surgeons to get the best within time, because time matters there. Platinum or golden time, what is important. And plastic surgeon, that the soft tissue, revascularization, all that. So to clarify a little on that, I thought it is the right platform to tell our executive director, it is a combined work between the plastic surgeon and orthopedic surgeons. So with that, thank you very much. I found from Jalandhar, from Punjab, from Tamil Nadu, from Telangana, all over the country people have come. It is only because Dr. Giri and his team has made such an impact in the national level. People, whatever happening in AIIMS, Bhubaneswar, people have been drawn. It is not a small work. People should have that much of trust, faith, and what he rightly told Dr. Tahir, end of the day, when they go there from here, they get so much of knowledge. And why we senior attend? Even I was attending a cadaveric workshop in Delhi, in All India Institute Anatomy Department in Delhi. They told, sir, you are so senior. Mukul, I am not senior. I want to abreast myself with the recent advances. Because what we have been taught 30 years back has completely changed in every aspect and every field of our super specialty, also in broad specialties. I hope for the young people, you are so lucky that with the shortest of your expenses of time and energy and money, you are able to be trained with the experts of the country being here. So that is the venue of which matters, and that's the place. And last we have the live operative workshop been done last time. What is unique? Nowhere in India a live operative workshop is allowed as per the NMC guidelines. But it could be possible to be here only in AIIMS. Thank you so much for that. And congratulations to all of the young residents and surgeons who have come from the orthopedics and also plastic surgery. Thank you very much.
Thank you, sir. Now I would request everyone to head forward towards the lunch area. Workshop will resume after the lunch. So everybody can actually go towards the front of the OPD so we can have a group photo.
Hello. Ready, sir?
हाँ हाँ ଶୁଣ ହ୍ୟାଲୋ ହ୍ୟାଲୋ ପଇସା ଦଣ୍ଡ ଢେକା ଖଣ୍ଡେ ଦେଇଦିଅ
Mitigations, you will see nonlinears, gap nonlinears, where you are going to use graphs. One mitigation. Second is comminuted fracture, high velocity fracture, where it is difficult to fix the wires. Right? So, and third indication, there is special group of patients. For example, boxers, okay, or athletes and racket building athletes actually. Those you cannot apply just the screws or wires, they want to go back to function early. Those are the patients where it's better to fix with the plate. The plate stands full of the metacarpal and you don't have any stress riser. So here we have demonstrated this video over fraction of the, this is a log of the fracture with some combination. It is clearly a mature patient. So you have to plan which plate will you use. So if you see your armamentarium actually, you will have different kinds of plates. So once this fracture pattern happens actually, whether it's in the diaphysis, in the neck, head or in the base. So you should be able to get at least minimum 3 screws in each fragment. Okay? So always remember this, 3 screws in each fragment. Sometimes you will have splash plate or you can use T plate also, or if a diaphysis fracture, a simple LCP can be used. How much diameter should be there? As sir has told us earlier, the diameter should be 1/3 of the diameter of the bone. Minimum that diameter has to be utilized. So most commonly used location, in this location we use 2 mm plate or 2.4 mm plate. You can use either of it, don't worry. Okay. So here, first is the important thing, the position. So always remember this position of hand surgeon. You must have read the first chapter in your book, where the surgeon should sit, from where the light should come, from where the image will be. Okay? So surgeon will be in the axilla of the patient, image will be coming from the longitudinal part of or from the opposite side, and the light will be coming from your shoulder. That's the essential thing. Then comes the exposure. So it's a lazy incision. If you use a longitudinal incision, there will be more chances of hypertrophic scar. And second reason is when you want to go to the bone, you want to cut the intratendinous junction of the extensor tendon. And second, the dorsal interosseous will come. You want to take as if a rested flap, okay, so that you are able to assist it back over the plate. That is the one reason why you should take a lazy incision out there, a dorsal approach. And never ever cut the tendons. So this is a short of the fracture. This is important, how to reduce the metacarpal fractures actually. So few of you would have, I think, are orthopedic residents also, the simple
his part is to reduce any fracture, give traction, counter traction. What they do? Hold it or pull it. In metacarpal, it's entirely different. It depends upon this. The reduction depends upon the ectortiae. Okay, once you flex the MCP joint and then you just push it, this will get reduced. This reduction maneuver is very important in metacarpal fractures. Then again, if you want to apply a plate, you can apply a plate. If you want to apply a screw, you can apply a screw. If you want to use the wire, you can use the wire also. So this reduction maneuver becomes very, very important here. So they are going to use this plate. Provisionally, practically, when you have this kind of injuries, you try to elevate the periosteum away from the fracture site. So that should be limited to 1 centimeter. In long bones, 1.5 centimeter. Don't strip full of the periosteum. Otherwise, you will devascularize the bone and there will be delayed healing. So the next step practical is you apply, you reduce it with the hair protection clamp, then apply fructal wires, then you apply this plate. Whether it's a T plate or simple LCP. And if you see these small holes, these are for the wires. These will be supplied with your armamentarium, and you check it before surgery also whether the wire is going from these holes or not. Because if you try to do with the usual thicker wire, then it will be difficult. But more wire distally, now this becomes stable. Then drill the screw and apply by taking a bicortical purchase in the bone. Now this is very critical. If you see, all 4 holes has been filled up, then they will go to distal part of the plate. Why? And these are locking screws. The first screw is non-locking screw. So if you just try to think about it, then they are applying the first non-locking screw or a cortical screw that is going to pull the plate towards the bone. So your implant will not be that occluded. And it comes in contact with the bone, and then they apply the locking screws. So this step is very, very critical. Then reduce, just check the rotation, as I have one of the things, how to look for rotation. All the fingers will go towards the escapulative velocity. Just bend it, you will see your fingers are going towards the velocity. And then if you see this is a compression, this drill is for the compression screw, this is an eccentric drill bit. So that arrows should be towards the fracture of the drill bit, and this hole will be in the far part of the plate. For example, this one if you see. This drill is not in the center. It's not in the center, it's in the side of the oblong hole. So what will happen? Then you will apply the screw. These are self-tapping screw. The fracture compression will happen. So this is very essentially important part. This is the thing that I was discussing earlier about pre-bending of a plate, in which sequence to apply a plate. This is another way they are using plate as a reduction tool here. Then fill up the other screws. And then so the wound closure is important, because whatever the periosteum or small facial just close to the dorsal ectortiae remaining, try to cover the plate with those periosteum the myofascial layer, because plate should not protrude out and should not impinge the tendons. And then obviously do the wound closure. This is how it will look like. And then you can immediately mobilize your patient. Don't apply these screws also and plates and keep the patient mobile for a long time. So this was from their side. I have shared my application also with you in the group. You can read that for phalangeal fractures.
Fixation also in the plate. I think they've got a 5-hole and a 7-hole plate. You can choose metacarpal or phalanx, just one plate, how to fix on both sides. One interfragmentary screw. We will do that in the next half an hour.
Okay, let's move to the
The idea is to give you more hands-on experience in the sawbone. The talk sir will share on the group, it's didactic. Minus supply.
And then
vertical screw once, and then that will pull the bone to the plate on one side. Then if you want to give compression, you use the oval hole. You start a little bit with that screw. You start the screw here, offset, so not in the center, it's slightly offset. Once you start tightening the screw, the plate will slide and this bone will slide under the plate. That's how you give it.
but manufacturing में direct basically plate नहीं but nobody is इसके बाद पॉकेट साइज नहीं है और काम में आप कैसा मैनेज करने के लिए सब कुछ कर सकते हैं नहीं किया
That was the misgiving. But over the next few slides, I hope you will have a little bit of clarity on that, and then will be more open to using it in your day-to-day practice. So the learning objectives of this talk are to discuss the principles of the use of the intramedullary screw. We learn about the indications, which fracture patterns where it can be used effectively. We learn the actual technique, and then I'll show you a couple of case examples. Okay. So I have to confess that some of the illustrations I have borrowed from the AO Trauma Surgery reference, and these are very nice resources where you can get some concepts very clear. So, principles of the intramedullary screw, it acts like an intramedullary nail, like a miniature intramedullary nail. It is most ideally indicated in transverse and short oblique fractures only, not for comminuted fractures, not for long oblique fractures. It is especially useful when there are multiple fractures. Then you don't have to do extensive dissections. You can just make tiny stab incision over the phalangeal head or the metacarpal head, and then put these intramedullary devices without much soft tissue dissection. So if there are multiple fractures, it's especially handy. It is contraindicated where, if you see on the X-ray that the bone has a very tiny, thin, genetically, some patients have a very narrow medullary canal. So if you have a very narrow medullary canal, you cannot put the screw. If you try to force and jam the screw in a narrow canal, it will just
break the cortex and you'll end up with iatrogenic fracture. You don't want that. So in those cases, you should avoid it. So this concern about articular involvement. So this technique was popularized by two people. There is a gentleman called Paco Pinal from Spain, and also closer to home, Dr. Chaitanya Mudgal from Harvard Medical School. He comes to our ISSH conferences. He was also here for the basic hand course, the Indo-US hand course every year he conducts. So he is also one of the pioneers of this technique. And I had a chat in depth with both of them and said, what are exactly the same thing, because I was always a fan of intramedullary wires, but I was afraid to put screws. Then they explained to me, if you look at the articular cartilage here, so this is a phalanx, okay? Just see what is happening here. What is the articular cartilage? It's like this. So it's not a straight line, there's a dip like this, yeah? And where is your screw going in? Through the middle. So the condyles on both sides are relatively preserved, yeah? So that's not so much of an articular damage and impact, and that void will fill with the hyaline cartilage goes away, but in its place fibrocartilage grows. It doesn't have the same mechanical strength as hyaline cartilage, but it will do the job. It's not like there's a big hole left. Nature will fill the defect with a different type of cartilage. Similarly, if you look from the side, what happens is, this is the part, we are putting the screw in line with the medullary canal, and the head is shaped like a cam, okay? So if you look at it here, working. So what I am trying to say is the medullary canal is in line with the dorsal part of the cortex, which is only this part. This much is the part which is going to be involved in the flexion. So that is 80%. Only the top 20% is involved, there. The 80% there is uninvolved. So it is quite safe to, as long as the trajectory is good. So as long as the trajectory is in the dorsal part of the, and you have the 80% volar cortex here, which is actually responsible for flexion. So the advantages of the intramedullary head screw, it is a minimally invasive technique as usual. See, need to wait for, in 2-3 days you can get the patient to move. It's quite stable. So what are the disadvantages? Disadvantages, there is because it's an intramedullary device, there is no proximal or distal locking. There is a risk of rotational deformity. So you have to be very clear that when you have put it intramedullary, the translation might be in AP and lateral planes might be corrected, but you should be sure that you check, like Dr. Tahir said, you have to check with 3 methods the rotational deformity. So you check the fingernail tenodesis effect and you flex the fingers and see that the cascade is maintained. There is no scissoring or anything like that. So you have to check for malrotation. It is easy to miss it, especially when there are multiple fractures. You need a reference point of at least 1 finger, or at least compare it with the opposite hand if multiple fingers are involved. The theoretical risk of the damage of the articular cartilage, yes, there is some articular damage, but it does not affect the clinical function or outcome, as there's evidence in several studies. It's not me saying it. There's literally several papers out there in the domain which have looked at this, and they have concluded, yes, there is no serious long-term implication in terms of loss of finger function because of this. So how do we choose the fracture? So I'm going to divide my talk into 2 parts. First we'll talk about proximal phalanx, then we'll go to metacarpal. Yeah. So the isthmus diameter should be at least 3 millimeters. So this one, it should be at least 3 millimeters in diameter. You can template it on the X-ray. The fracture line, it cannot be a fracture here in the head. It has to be in the neck, and the gap between the fracture line and the articular surface should be at least 6 millimeters to allow the head of the screw to be seated subchondrally. The head of the screw cannot be protruding into the joint. It has to be buried under the bone. That requires at least 6 millimeters. So the fracture line ideally should be 7-8 millimeters here. For any more distal fractures, this method is not suitable. Yeah. Usually for the phalanx, 2.4 millimeter screws are used. And the ideal indication is either transverse or short oblique fractures. You have to be very careful about the rotation. I am saying it again and again. And
you have to make sure that the cascade is maintained. You cannot afford scissoring of the fingers or malrotation. And if that is required, you can digitally rotate and correct the fingers. So let's talk a little bit about the entry point. So if you look at it, this is the end-on position, and you can see this is from the side. So this is quite dorsally in line with the medullary canal, and most of the volar part, which is the overhang here, the articular cartilage is not affected. So it's something like this. For a retrograde insertion, this is the dorsal to center articular surface, and that is the line of the screw. So I think you have appreciated that. Okay. So how do we do that? So first, we do the guide wire insertion. How do we do that? It's a percutaneous insertion through the skin. It is made parallel to the dorsal cortex here, and in center. The plane of the wire should be checked on AP and lateral views on the image intensifier through the central tendon and parallel to the dorsal cortex. That is how you drill the guide wire. Once you have done the guide wire in and you have checked on the AP and the lateral views that it is in the same trajectory which you want it, then you have to introduce the screw. So that is not percutaneous, then that is where you start making a small incision. You make a small transverse incision on both sides of the guide wire in the skin. This needs to be only about 3 millimeters. It doesn't have to be a large incision. Then you use a mosquito forceps and open that a little bit. What you see underneath is the central tendon through which the guide wire has gone. So in the plane of the guide wire, you make a small longitudinal nick, not transverse. So transverse to the skin, longitudinally in the plane of the extensor tendon where the guide wire has pierced the central tendon, just release it a couple of millimeters on both sides. So then you can use your mosquito again in the split you have made in the tendon and spread the jaws widely. What you will find is directly you will encounter the head of the metacarpal. Yeah? So longitudinal split in the central band, that gives you access to the head of the proximal phalanx. Once the bone is exposed, you can use a sleeve, and then you can use the drill bit. So what you do, you choose the appropriate diameter and screw length. So that you template beforehand. You can use a depth gauge and measure the size of the screw. You can actually overlay the screw on top of the medullary canal of the finger and see that the length is sufficient on C-arm. Then you insert the screw over the guide wire and bury the screw in such a way, so you see here what is happening. The shaft of the screw has crossed the fracture line. The threads are engaged in the isthmus, so it is holding the cortex distally, and the head is completely buried in the bone. These 3 criteria should be fulfilled. You cannot have the threads in the fracture side, that will distract the fracture. This will not give you compression. You cannot have a screw length which has the head sticking out. So this has to be buried. The shaft of the screw has to cross the fracture line, and the threads have to engage in the cortex here, and preferably in the isthmus. That would be your ideal fracture pattern. Screw thread should cross the fracture line, and the threads of the screw tip should engage the bone. I have already told you that. Yeah. So what is the aftercare? So usually after this, we talk about early mobilization. Early mobilization doesn't mean that the day after the surgery immediately you have to move the finger. So you can you can go for the same thing. Immobilize in the safe position, keep the hand elevated, give them analgesia so that the patient sort of recovers a little bit, especially if the post-op edema comes down. The injury also would have caused some swelling and edema. Let the edema subside. When the patient is comfortable, as pain tolerates, you can give them active range of mobilization. That can be within 2-3 days, that can be within 4-5 days. The choice is there, but that still constitutes early mobilization. Yeah? So basically, splint in a safe position till swelling reduces, then you can commence early mobilization. Now I'll go for some case examples. So this is a young 27-year-old male who came to us. Now if you look at it carefully, this is actually the end-on view of the cortex of this fragment. Yeah? And if you look at it here, it has become almost 90-degree bend. So I have marked it out for you so that you can understand more clearly. That is how it is. But the good thing here is when I saw this case, I had recently come back after my talk with Paco Pinel and Dr. Mutkal. I was looking for a case to try my newly learned technique and knowledge, and this came as an ideal case. So went ahead and did it, and I was very pleased with the results. Okay, so the patient went on to have a good result. Just a small nick, and that's it. So this is a 3-month follow-up. You can see it's healed quite nicely without much problems, no articular issues, no stiffness. Then someone asked me about an oblique fracture. I think it was you, yeah? I said I would show you in the afternoon. So this is an extended indication for IMHCS.
This is a 31-year-old lady came to us from Tripura, homemaker. 14 months since injury, but that was COVID time and all the flights were cancelled and she didn't even seek medical attention, didn't venture out of house. She came with a rotational malunion of the P1, so proximal phalanx. Okay, so you can see that finger is sticking out of the way, looking London, going Tokyo. So this was the X-ray. You can see it's healed, but there is a rotational deformity, malalignment. So the plan was, she said, I cannot. Every time I flex my finger, this is going this way. It's very difficult for me to work, even knead atta, anything, hold anything, do her cooking, her finger was pointing the other way. So she wanted a correction. Now normally what would you do? For an osteotomy? You would do an osteotomy like this, follow the plane, then you would put a plate. Would you put bone graft? Maybe, maybe not, I don't know. But it's a hassle in such a tiny finger to put a plate, make a osteotomy to recreate the plane. So I thought the fracture is healed. It is the rotation which is the problem, right? So why do we have to go with the oblique plane? So we decided we'll do a transverse osteotomy through a small midaxial incision. On the lateral aspect, we made a small incision at the neck level. We created the ideal fracture pattern suitable for an intramedullary head screw. Then we derotated the finger and put an IIMS. So we did the osteotomy correction in a malunited, it was an oblique fracture, but it had malrotated and healed. So rather than create an oblique fracture again, we just created a transverse fracture at the neck level, which would be ideal because here we were playing God, we were creating the fracture line to suit the implant. See what I mean? That's why I said it's an extended indication. So this is what we did. That is the fracture. We templated the screw size, so you can actually do it by placing the screw and getting the length right, where the head would sit, where the end of the screw would sit. We make the fracture line or the osteotomy to suit the implant. That's what we went and did. We did the osteotomy, then we passed the guide wire. Then we derotated the finger and drove in the screw. And what was like this before has become like this. This is immediately on table after correction.
You have to remove some bones?
No. There was only a tiny spike, didn't bother. It was purely rotational. Percutaneous. This is the functional result at 6 weeks. So that was an extended indication, yeah? We can do it for deformity correction. This is another male patient. This is not my case, this is my colleague, Dr. Arya Rai. Some of you might know him. He's a hand surgeon in Kolkata. So this is a base of the proximal phalanx. So again, he wants to try some new ideas, very innovative. So he said, I will do a HCS on the base. So this is a antegrade entry here after correction, and that is how he put his screw. It has been described. Now we'll come to metacarpal fractures. Principles are more or less the same. You can either go for a similar antegrade entry or a retrograde entry. Both have been described. Main indications are simple transverse fracture, and sometimes it is simply a surgeon or a patient's preference about early mobilization. Some might argue a K-wire will give you the same result. Yes, you can use a bouquet technique, you can put K-wires. Some of the transverse fractures you can treat conservatively. There is no right or wrong way. I am showing this as one of the options. Yeah, I am not saying this is the only option. So the contraindications are again, if you have to have enough bone stock. So the fracture cannot be almost subcapital. There has to be enough bone stock. So this has to be at least 10 millimeters. Otherwise, you cannot do this. So technical considerations are, they should be at least 10 millimeters, the fracture line. The isthmus diameter again should be at least 3 millimeters. Usually 3 millimeters in wider canals, especially in Caucasian patients with heavy build. You can use up to 4 millimeter screw also diameter sometimes. The reduction technique, I think sir has already talked about. We use a technique called the JAS maneuver, where the finger is flexed, the proximal phalanx is pushed up against to reduce the metacarpal neck. So this maneuver is called the JAS maneuver. It is very commonly used in hand surgery to reduce the metacarpal neck fracture. You flex the MCP and PIP joint to 90 degree. Use the proximal phalanx to put upward pressure on this fracture site and reduce the tilt. Use the proximal phalanx to push up the metacarpal head. Then comes the entry point. It is pretty much similar. Hold it in 90 degree flexion, small transverse incision. incise the extensor tendon and identify the metacarpal head. It's usually a longitudinal split in the tendon. Insert the guide wire, again same, just like I had described before. Under C-arm, use the C-arm to make sure the tip of the guide wire reaches the base, don't penetrate it. Correct the rotational alignment. Then you insert the screw. You can pre-drill the entry point somewhat. Although some people say it's self-drilling screw, sometimes at the entry point you can make a small, you can drill it a little bit, and then you can choose the screw of appropriate length and diameter and pass it down. And the technical presentation about the thread length and how it should be buried in the bone and how it should engage this much is all the same. So here you should see basically the thread should cross the fracture side. This should be engaging the isthmus and this should be buried in the bone there. The fracture should be compressed. You confirm it again by C-arm and clinically you check the cascade once again. So regarding antegrade entry, this is what I have said. That was retrograde, this is antegrade. So here you can incise it in these points at the base. So this is antegrade entry. You can see for second, third, fourth and fifth metacarpal point, the entry points have been marked. You have to protect the extensor tendons in a similar way, and then guide wire is drilled like this, and the screw is passed in an antegrade manner. You can use a 14G cannula IV sheath to protect the guide wire as a drill sleeve. You drill in line with the medullary canal and the wire should go right up to the subchondral bone. So this is an antegrade entry. Now what sometimes happens is, it is difficult sometimes to get the wire to go like this. So you can start off with the retrograde entry. Then what you do is you flex the wrist and advance the guide wire so that it comes out from here. Where it tends the skin, you make a small nick and make the guide wire come out of the dorsum. Pull it out to the appropriate length. So you can do a technique like that. Pass it retrograde, flex the wrist, drill through the metacarpal base. The skin is nicked where it tends the skin and withdraw the guide wire proximally to the appropriate length. And then it becomes like an antegrade standard insertion. Screw insertion is again re-drill the base of the phalanx here and the metacarpal here. Screw is passed similarly, buried in the bone, crossing the fracture side. Same technical concentration. Aftercare for this is also similar. You can put a temporary dorsal splint till the swelling subside, then commence early mobilization. So after the splint is removed, sometimes you can use neighbor strapping or buddy strapping to allow mobilization. So, couple of cases, one case example I'll show you and then we'll go to the exercise. So, like I said, when God is kind to me, He is really kind. He sends me this kind of patient. Not only that, she's some big multinational company, she's a corporate lawyer and she's only 26, it's a dominant hand. She had an RTA and she came with this kind of injury. So, before the patient comes to me, I get 5 or 6 phone calls and then I get to see the patient. So that is the kind of pressure of working, So this is the clinical picture. You can see the skin is not very healthy here, quite swollen hand. What are you afraid of in this kind of scenario? Compartment. Yes, I know. I was almost tempted to do a formal release and everything, but then this is the fracture pattern. So you see this is what pattern? Transverse oblique spiral, what is it? Just metacarpal? Transverse. Fourth? Third? And then second? Intra-articular base. So, one option would be to debride the whole skin, do a formal release and then start planning your hardware, maybe put 4 plates for 4 metacarpals. Then we thought about this idea, what we can do. Although it looks quite swollen, it wasn't as if, clinically it didn't look like a compartment syndrome, although it could have gone into that. So anyway, we took a leap of faith. This was the lateral view. So, templated and did a percutaneous intramedullary headless screw for the 5th first, then we did for the 4th. So this is how the insertion is. So one goes in like that, and we did the similar thing for the next one. And after we had done 2, this was where the skin was compromised, so we could get away with small nicks here, away from the area of compromised skin vitality. Then we were left with this and this. we thought this is no way we can, get away with the AIIMS. It's not a suitable fracture pattern. She's a lawyer. If it doesn't heal, we are going to get sued. So that pressure was always there. And then there was this intra-articular fracture. Then we decided to bite the bullet, decided to plate the second and third through a single incision placed in between the second and third. So that's what we went to do. Here we went, opened this here. This is the fracture. This is after fixation, so we decided to grade this. So this would have been a good workshop case. Everything which you learned in the workshop, in one case you have done everything. Yeah? So this is the view. This is the immediate view after surgery. In fact, the swelling wasn't that bad. The cascade was reasonable. This is her function at 2 months. We offered her something for this. She's saying, I'm happy with this. I'm not coming back. I got my movement back. मेरे को time नहीं है, काम फुर्सत नहीं है, बहुत busy हूँ. So as long as patient is happy, we are not complaining. So in conclusion, intermediary head disc is useful in transverse and short oblique phalangeal and metacarpal fractures. It's a minimally invasive technique. It doesn't cause any implant profile, no soft tissue irritation, single fixation. You can mobilize the figure early. No implant removal required routinely. The fear about articular damage at the entry point seems unfounded, at least as far as the studies go so far. But last but not the least, you have to be very meticulous about the fracture patterns. So the indications have to be right and the technique has to be meticulous. If you follow these two, you will get a good result. Thank you very much. I think we go to the soft one and do this. So we'll take any questions on the soft one while we are doing it, because we are running short of time. We've got one more scaphoid module and plus one rehab talk also. So let's go to the
This is not an experience of studying the
Every time it's we did all take yesterday's case.
And you want to know the screw size, what do you want to take? आराम से कर नीचे करिए ना, हाँ वॉबल नहीं करेगा। थोड़ा जोर लगाइए। वर्कशॉप लंच के बाद हो रहा था।
भाई देखो ना एंट्री दिशा गाना उड़ा है
जा रहा
और आप करिए ना
जा रहा फॉरवर्ड तो उसको फॉरवर्ड करो ना, फॉरवर्ड है हाँ
The assistant has to hold the finger in flexion, check, and then while holding it like that, do the final seat. Otherwise it will seat slightly different. And then it is difficult. If you unloosen it and then recorrect it and then the grip will be gone. If the grip is gone, then it will never be the same. So before you do the final seating, do a rotational assistant check. Not necessary. But the screw is only engaging in the narrowest part of the medullary canal. Here it is just floating in the medullary canal. It doesn't have any grip. So that length really doesn't make too much of difference. The grip is actually in the narrowest part of the medullary.
Without object confusion, wires, screws, different kind of screws, and everybody is trying to
achieve optimum outcome. Why this bone is important actually? If you see, this bone is connects two carpal rows and it has got 4 surfaces and very precarious blood supply. So it has got retrograde supply, it's very prone for avascular necrosis, and mechanism of injury is very certain. We have studied the bone a lot, and this bone gets fractured if you try to extend your wrist beyond 95 degrees. If somebody presses below that, it will get fractured if there's a force, and if there's hyperextension with translation, then the proximal pole fracture will happen. So if this patient comes to you, how you should deal? As per evidence wise, if you see, because the incidence of missed injuries are 14% and chances of union are very high. So if you see this chart, you must see 4 clinical signs. One is tenderness in the anatomical stuff box, longitudinal compression of thumb. You just press the thumb of the patient if he or she complains in the pain in the wrist or anatomical stuff box. You press the scaphoid tuberosity. You know where the tuberosity is? Where your pisiform is. Just press the pisiform. Just press it and come transversely towards the radial side. You will feel a piece of bone. That's scaphoid tuberosity. If you press that bone, which it has tenderness, then there are very high chance of fracture. Then the fourth is ulnar deviation. If a patient does ulnar deviation, patient has pain, that's the 4th sign. So if you see, all these signs are very sensitive, but specificity comes down very low. So you have to do at least 3 tests. Then the specificity comes to be 0.74. So a simple way of saying is you must do at least out of these 4 tests, 3 tests needs to be done. And every clinically suspected scaphoid fracture should be investigated further in terms of other investigations. So what investigation should you do? As per American College of Rheumatology, how many X-rays should be done? It's not wrist, AP, lateral, that's sufficient. That's not right. Should do at least 4 mandatory views: PA view, PA with ulnar deviation, lateral view, and semi-pronated view. Okay. So just a small story to you. Do you know, as per evidence, what is the most common cause of medico-legal cases in UK in upper extremity? Is discophyte fracture. So that train may come to our country also. So be informed. So do you know what's wrong with fixation of the discophyte? Anybody just raise your hand? Yes? This screw is fixing discophyte to lunate. So radiology is not that simple. It's easy to say scaphoid, but identifying the scaphoid bone itself is the first step. The scaphoid is this one. If you see, that is the scaphoid bone, proximal row. If you see, this is the proximal row. That is the largest radial bone. That is this is lunate. Similarly, in the lateral view, the scaphoid is 45 degree to this point. That is the scaphoid. That is the scaphoid. Okay. So first step is you should be able to identify the scaphoid. And I hope none of you will do this mistake. Okay. You should never ever do that. So you should do 4 views. One is PA view. You must see the ring sign. The ring sign means the scaphoid is 45 degree. It is getting flexed because of the fracture. The kyphosis is happening. So if you see this, that's the ring sign. That should cover only the distal 1/3. It is covering more than that. Then that's called ring sign. You should be able to see the base fracture, the fracture pattern, because few fracture patterns, for example, the oblique fracture pattern, the combination, that suggests unstable injury. And associated injuries means if you see a little bit more suspicious, do you see something else? This gap? Is it more than that? Yes. So that gap suggests sometimes associated injuries as that gap. That suggests scapholudate ligament injury also. So this view is important. Second is PA with ulnar deviation, as initially explained in the first or second lecture, that extends the scaphoid, that comes in the plane of the X-rays. That is the reason it becomes fully visible. If you see, this has also come out. This is especially important for proximal pole fractures. The semi-pronated view, you see, this part becomes more visible, and the curvature of the scaphoid becomes, you can see the displacement in this view better, and this part, the distal part fractures or the scaphoid tuberosity fractures, that becomes visible. So this view becomes important, especially when you operate the scaphoid. If you see this margin, that is the lunate. Can you see this margin? That is the scaphoid. So there is 2 mm gap. Scaphoid is a little bit distal because the lunate fossa is a little bit more in depth than the scaphoid fossa. It is something like this. So scaphoid will always be a little bit more distal. So always remember. So if you have done all these 4 X-rays, any idea kitne X fractures you will be able to pick? In our setting, we are doing 2 X-rays or so. We are missing lots of injuries. Even after following this standard criteria, you will be able to grab only 84% of the fractures. You are going to miss 16% even after 4 X-rays. So what happens with the remaining 16%? Okay, the classical teaching has been you apply plaster for 2 weeks, do the X-ray. But if you see, this has led to poor inter-observed reliability, and patients are going to miss their job because of no injury also for 10 to 14 days. So as per NICE guidelines, standard is If you are suspecting scaphoid fracture, do MRI. There is no doubt about it. There has been nice guidelines in the UK actually, but if their guidelines, you are not following it, we don't have our own guidelines, then also again, if you miss something and somebody goes in court, we may be in soup also. So always remember, CT scan is done for surgical planning purpose, but it's different. Once you write in the paper CT scan of scaphoid, you should not write CT scan of the wrist. If you write CT scan of the wrist, they will take sections in this plane perpendicular to the wrist with 1 centimeter of sections. If you write CT scan of the scaphoid, they will take sections in the plane of the scaphoid. Scaphoid is something like that. They will take perpendicular to this plane with 1 mm or 2 mm sections. So you will have a better chance of finding a fracture, a better morphology will be present. If you see, where is the scaphoid? Again, my first question will always be the same, where is the scaphoid? So this is the scaphoid, this is an oblique fracture, a little bit of non-union. And if you see the sagittal sections, that is the scaphoid. So it's getting flexed. That's called kyphosis. The axial view, that is the scaphoid. And that is the fracture. So train your eyes for where is the scaphoid? That is the scaphoid that is getting flexed, leading to inter-scaphoid angle more than 15 degree. Or maybe just a simple language, scaphoid is getting flexed or twisted on itself, getting bent. Kyphosis is happening in the scaphoid. So this is a sign of instability also, sign of fracture also, both. Now the classification part comes. You should not keep goats and sheep together separately. You should be able to identify the prognostic which are going to do better, which requires a little bit aggressive treatment or operative intervention or different kind of protocol actually. So anatomically this is a classical proximal 1/3, very prone for AVN, middle 1/3 may be treated conservatively or operatively, distal 1/3. You require usually a cast. And Herbert Fisher, that's another one, you can go and see it. I will not go into detail, but broadly you can see these are divided into undisplaced stable fractures or displaced or unstable fractures. So what is undisplaced? If you see any kind of displacement more than 1 mm, that's displaced. Undisplaced stable means there is no displacement, no kyphosis. And most of the time the fracture is in the waist or distal 1/3. If the fracture happens in the proximal 1/3, it is unstable injury. Okay? So always remember these markers of instability in terms of combination, oblique fracture pattern, translation, kyphosis, proximal part. And indication of surgeries are basically in the displacement is more than 1 mm, combination, kyphosis, all these are parameters for instability. Now coming to the cast part, the most important treatment has been the short scaphoid cast. That means a below elbow cast. Long scaphoid means included thumb above elbow, or below elbow excluding thumb. Why this controversy, including thumb, excluding thumb? Because there has been these, in literature there has been no difference actually. And why we have to keep the thumb in when there is no difference? So we have this protocol actually at AIIMS where we include the thumb when we have these group of patients. When the patient is hyperlax, beaten score is more than 5, we include the thumb. Simple. Next is non-compliant patients. Some of the patients will go home and will start using the hand if you don't include the thumb. Those group of patients, or the smokers, because smoking itself has led to non-union, and that is the cause of very bad prognosis in scaphoid fracture patients. Now coming to the operative part, it may be fixed dorsally or volarly. That Dr. Ravi Bhardwaj will show you the technique. I will upload this theoretical part in the group. You can read that. This is all theoretical, but more important is how to fix that with the Herbert screw or that kind of screws. Dr. Ravi, your surgical technique.
No. So let me simplify this. So basically, let's talk about acute fractures and then fractures which are not so acute, maybe 6 weeks, 8 weeks later. What is the role of CT? What is the role of MRI? So CT is not the primary for an occult fracture, which is radiologically negative on the standard views, but high clinical index of suspicion. There is anatomical box stiffness, scaphoid, all the tests which Sir spoke about. If more than 3 of them are positive, but on X-rays, despite using the standard views, you are not able to pick up a X-ray. Classical teaching was 14 days in cast, re-X-ray, but again, like Sir said, so now the protocol is you get an MRI. Those fractures which are not visible on standard X-rays but are clinically positive for a scaphoid fracture, those come under the category of occult scaphoid fracture. The investigation of choice, gold standard, is MRI. CT will give you in an acute setting. If you are thinking it's an undisplaced fracture, should I fix it percutaneously? Then you apply Mayo-Cooney's criteria, whether that's 1 millimeter displacement or not, whether there's comminution or not. Can I do a percutaneous fixation? Should I do open? The diagnosis of scaphoid fracture is made, but for to better idea about the displacement, the anatomy, the alignment, there you get a CT scan, and the CT has to be prescribed as, like Sir said, CT for scaphoid fracture with 1 millimeter cuts in the long axis of the scaphoid. That has to be on your prescription. You cannot write CT list. You will not get good CTs. Musculoskeletal radiologist. So this is in the acute setting. After 6 weeks, what is the role of CT? For fracture union, the best guide is CT. Again, X-rays might be deceptive. You might think one cortex is sealed, one side small gap. So just to make sure that you're medically legally safe to take off the cast, whether the fracture is healed, then you can get a CT scan. Late setting, people get MRI scans for avascular necrosis. There's a lot of controversy about that also. And that was largely because, whether the standard MRI can pick up marrow signals which are correlating with AVN, and to call it an AVN, what kind of special sequences you use. But that difference has largely gone, because if it is not united, AVN or not AVN, previously the tendency was we would do vascularized bone graft for AVN, and if it was non-union, we would just do a simple bone graft, like cancellous bone graft and an internal fixation screw or whatever. Now there have been studies which show no significant, so the literature says a 92% chance of versus a 88, 89, I think it's the paper from Shin, 88% versus 92%. That's a 4% difference. Whereas technically, the expertise for a vascularized versus a non-vascularized, it's like chalk and cheese. Any standard surgeon can do a normal, but you need a little bit of microvascular training. For you, it might not be a problem to do a vascularized bone graft. For an average orthopedic surgeon, it's a problem. So because there is not so much of a significant difference, most people would do a normal bone grafting, even for an AVN. Answers the question. So let me go to the part where we are talking about techniques. So this was all the standard talk, CT versus MRI. I told you this. So Sir has already spoken about all this. Okay, let us talk about percutaneous fixation. So the absolute indications for surgery would be if it is displaced more than 1 millimeter. If it's a proximal pole, it is a relatively more even tilting in favor of surgery. If there's comminution, if it is a part of a perilunate dislocation, a transscaphoid perilunate dislocation, or there is a humpback intrascaphoid flexion, then these would tilt the decision more towards surgery. Okay. So percutaneous fixation is indicated in non-displaced fractures. If the fracture is displaced fracture, then you can go either volar or dorsal. So this is a dorsal approach, this is a volar approach, but irrespective of whatever you are doing, you have to make sure either it's an undisplaced fracture or that the fracture is you are able to reduce the fracture anatomically before you are doing the percutaneous fixation. Okay. So volar approach, what do we do? I'm just going to outline the technique, not going into too much detail. So for this, a rolled sheet or a towel under the wrist is must. So you have to put the wrist like this. Usually, if you dorsiflex the wrist by placing a rolled sheet underneath the wrist and ulnar deviating, then that would bring the reduction and will also bring the profile of the scaphoid. It will bring up the tuberosity, which is your entry point. The problem is the scaphoid is a curved bone and you are trying to put, where's the pointer? Okay, yeah. So you are trying to put, you are trying to put a straight guide wire and a straight screw along the long axis of a curved bone, which is like a twisted peanut. So there is no actual medullary canal like a long bone. It is like a twisted peanut, a carpal bone. But still we are trying to put a straight screw down a curved bone. So that is the problem. So entry point should be very much careful. It should be on the tuberosity here. And then when you have the rolled up along the long axis under C-arm, you pass the guide wire at a 45-degree angle in both planes. So like this, then you drill and then you introduce the screw. So your trajectory entry point should be somewhere here. This is how it should look. And then you check on other views also. And then you use the cannulated drill bit to drill over the K-wire. So you have to make sure you cross the fracture side all the way up to here. And that's how your screw should look like. So for dorsal approach, you make a small nick. Again, you bend the wrist like this. The rolled towel is like this. So the entry point is just adjacent to the scapholunate ligament. It is better not to use a purely percutaneous technique, but to use a mini open technique where you actually, move away the tendons from your field of vision and, make a small inverted T-shaped capsulotomy. Flex the wrist, the proximal pole will come into. Then you pull on the thumb. Longitudinal and radial abduction of the thumb will align the scaphoid. With the scaphoid flex, the proximal fold comes up and the entry point is just adjacent to the scapholunate ligament. Aim along the axis of the thumb like this. Your guide wire should go along the axis of the radially abducted thumb, and usually at that trajectory under C-arm guidance you will be able to pass your guide wire right in the center of the proximal pole going into. The proximal pole is a small fragment. You have a lot of control over the entry point. So it is relatively easier to do a proximal pole fracture from the dorsal aspect rather than, from a big fragment going to a small fragment accurately is difficult. But going from a small fragment to a big fragment is relatively easier. The margin of error is slightly more. So that's how you do it. And then you pass the screw. The guide wire measurement is all the same like you have done for small bones, the HCS. And that's how it's going to be. For open surgery, because it's a non-union, is very common in displaced fracture. When there is AVN, when there is a part of carpal instability, the goal is realignment and stable fixation. You would go for open surgery. This is the Wöhler-Palmer approach. This is called the Garcia-Elias approach. It is just like a curved thing. Linear longitudinal incision along the distal part of the FCR tendon, curving like this at a 60-degree angle into the thinner eminence base here. So this is the indication. So, and for Palmer approach, what you do is, at the dorsal approach, sorry, and this is one of my earlier cases, so I had opened it for a different indication, but you won't need such a big incision. This is the Lister tubercle, so here you would make a small mini open, then you would do a small, pull aside the tendon. This is the dorsal capsule. You would make a small inverted T-shaped capsulotomy, and then you would see the proximal pole. Okay, here let me see if I can show you the technique. So this is the Wöhler technique. So roll towel is under the wrist. You mark the outline of the scaphoid. It's like this. Is the volume there? Okay, I will talk my way through it. So FCR is dissected till the distal insertion, then you retract it. Once you got the FCR out of the way, you see the Wöhler capsule. So retract it. See, I'm just using my small Langenbeck here. And then with blunt dissection, that white shiny structure is the Wöhler capsule. Sharply dissect the radioscaphocapitate ligament and Wöhler capsule along the line of the marked scaphoid. Yeah? So then you get the fracture itself. You put a needle, like Sir said, it is very easy to get your landmark wrong. So it's always a good idea to double check, put a needle in what you think is the non-union site, especially in a long-standing non-union or a fracture. You can put the needle here and check in the C-arm that you are in the right plane before you proceed to freshen up. So that is how it is done. And once that is done, then the rest of the point I have showed you. Yes, yes. At least that's the way I do it. Then you have the guide wire being drilled. Sometimes you have to make a separate entry point, not through the same incision, because the scaphoid is such a bone. Sometimes you have to take an entry through the lateral margin of the the trapezium. So this is how we are putting the screw and measuring it. And this is a different system. So this has got three markings: the green, the yellow, and the red. So if you insert the screw up to the yellow mark, it is flush with the bone. If you insert it up to the red mark, then the screw tip is, the head of the screw is buried inside the bone. So that's how it works. And this markings tell you how deep the screw has gone into the bone. Once you have measured it, you twist it. And this is the final sort of seating, post fixation. You just check in multiple views, like so. That is the fixation. Okay, so this was a different case. Let me. So this was a non-union, so I was planning to do a bone graft, so I have made a bigger incision. But for a fresh case, for a dorsal approach, a mini open is enough. So it's again, you make a T-shaped incision. Once you've retracted the tendon, this is the dorsal capsule. You flex it. Identify the non-union site by flexing it. You will see this. Again, put a needle and confirm on the C-arm. It is always very, very important, especially it is very difficult sometimes to find out the actual fracture site because the cartilage has grown over it. Always better to double confirm with the needle. Yes, this is where I want to be. This is where I'm going to put my osteotome and make the area raw. Otherwise, you cut into some other bone and you find that you are in the wrong place. Just like spine, wrong level, wrong level, wrong level. So similarly, lots of small bones. You don't want to be cutting the lunate, or you don't want to be cutting any other bone like Sir Short. You don't want any horror stories, especially when you're starting off. So confirm this. Once you've done that, so this is then you passing the guide wire. And just speed up. And then it is very simple basically. So basically, once the guide wire is in, you check on the C-arm that it is in the right plane. It is relatively much more easier to enter from dorsal into volar like this. You follow the abducted thumb, and this is how the screw is put in, the same system of the headless screw. Let's see if the volume is high. Then I'm tightening it. Sometimes you use an additional K-wire for fixation. While you're putting it, it tends to rotate. Yeah, so you have to make sure that you have a second wire in place. This is the fixation complete. So it's easy to go from volar from proximal to distal, and this is a 3-month follow-up. This is the site from where I had bone grafted. Okay, so that's it. Take home message: have a high index of suspicion, get proper views, MRI for occult fracture, CT for fracture geometry, identify stable and unstable fractures, and plan your treatment accordingly. Okay. So what we are going to do now is we have come to the last module in which we will be doing the HBS2, that is the KLS Martin version. So we'll do it on the scaphoid model. So while we are there, we will talk about the technicalities, percutaneous versus open, how to get your landmark, how to get the screw trajectory, what views. We will do it, we will circulate and we'll discuss that. And once that is done, it's 4:30. Let's allot ourselves about 20 minutes. We'll have to wrap it up in 20 minutes. Then we all come back here and we have the last lecture about rehab, which is a very important, because all that you're doing is only 50%. The remaining 50% which will determine the outcome is the last 15 minutes of today, which is the most important part, the rehab. You don't want to miss that. Okay. So we will do the exercise for 20 minutes or so, then we'll come back and complete it. And then
Dr. Vigiri will be kind enough to give you your certificates provided you have filled in the feedback forms. Only then.
Only 12 people are people.
So only 12 people are going home with certificates. The rest of them are not getting certificates. Dr. Giri has been very strict on that. He has told me specifically no feedback form means no certificate.
All CME data, everything, it is a ISSH certificate is there, so
Enough, I think. Yeah, come out. Oh, sorry. Okay, fine. Why? What happened?
I came out through the student कुछ कर रहे हैं.
I came out through. ठीक है.
चलेगा.
Enough. Next day.
Have to get points.
And for dorsal, this is the scapholunate ligament. Will be here. Flex your wrist. You'll never be able to get like that. Flex your wrist. This part will come out like this. This is the scapholunate ligament. Just adjacent to this. This is your entry point. Hold your thumb, abduct it like this. So aim from here along the axis of the thumb. Do it like this. Say for example, I'm holding it like this. This is the abducted thumb. Hold it like this. So you can see if I'm aiming from here, the abducted thumb, it will go the axis. From here, I aim in the general direction of the abduction. With the wrist flexed like this, yeah. Entry point just adjacent to scapholunate ligament. From here, aiming towards the radially abducted thumb. It doesn't need to go up to the opposite cortex, it can stop this way. Axis is usually here. So a screw which is going up to here is enough. You don't need to hit the opposite cortex.
For a proximal cortex, preferably dorsal approach.
For a proximal pole, it is dorsal approach. For a waist, you can either go dorsal or lateral. But if you have a flexed scaphoid and a bone graft, then it is better to open polarly, put the graft, and then otherwise the scaphoid is flexed polarly. You have to open it up and there's a gap where you put the bone graft. So instead of here, it is open. So here it is better to put some corticocancellous bone graft.
So this working across.
But if you bend your wrist and do it like this, you see what is happening here. In bending the wrist and deviating, this is bringing this out. So sometimes you have to raise the trapezium. The entry point is here. Then open. So this is the scaphoid tubercle. This will be the entry point. So it is on the AP view, it is on the edge. This is the tubercle. On the lateral, it will be the middle of this. And you have to aim for the middle of this. So it will go almost as a 45-degree angle like this.
The idea is to get it like this, yeah, in this plane. It should be in the center, not exiting the proximal pole. It should stop somewhere here, but the trajectory should be going like this. So you have to not only lift your hand like this, but 45 degrees. So from this 45 degree and then 45 degree like this, then it is the right direction. And it should not come out from here. And on C-arm, you should rotate it in all views and see that the guide wire is inside the ball. Once you achieve that, then you drill, you take the measure the length, and then drill, and then pass. Do it. This is the green one, green screw. Because usually waist fracture, you can go either dorsal or volar. So for dorsal, what you do? Oh, the thumb is gone. So anyway, do we have a model with the thumb?
That's why we can go.
This was the thumb. Imagine like this was the thumb. So basically you flex it. Once you flex it, proximal pole is more visible. Just adjacent to the scapholunate ligament, that is the entry point. Here is the fracture. You will aim the thing again 45 degree. You hold the thumb abducted. So if I am doing the axis of the thumb. So suppose this is it and this is the abducted, radially abducted thumb. I flex the wrist. I aim in the trajectory like this. I don't need to go all the way. For this, just crossing the fracture, this much length is enough.
Direction of penetration will be along the axis of
Direction of introduction of the wire will be along the radially abducted thumb. And then just entry point is just adjacent to the scapholunate ligament. So if you enter from here, you will be in the center of this fracture. So initially, it is better to make a slightly bigger opening and then see the whole proximal pole. Otherwise, you will go here. The whole fracture is actually here. You are going here. The fracture is here. And you are entering through here. You need to be in the center of the proximal pole. So a little bit of more dissection of capsule doesn't matter, but accuracy is more important.
This is the tubercle.
Here.
धक्का दे रहा है लेकिन मुझे नहीं पता
नहीं ड्रिल करना पड़ेगा
आ गया थिंक आ गया
निकाल दो गो बैक
रिवर्स कर दिया
ये आ गया जस्ट आ गया रिमूव इट गो बैक
हाँ हमको वैसे तो निकालना ही है
यस इसको तो निकालना ही है then only will be able to put the screw then you take a screw
परक्यूटेनियस लीवर दूसरे यहाँ से डायरेक्ट जाता
So just adjacent to the scapholunate, you have seen just do a little bit of shape capsulotomy like this. You take the flaps of the capsule, you expose the whole proximal pole. Then this is the scapholunate ligament. Just adjacent to that, in the center of this, you make your entry point. What should be the direction? You see the whole proximal pole dead in the center, you start your entry point, usually adjacent to the scapholunate ligament. Radially abduct the thumb. So when your thumb is like this, your guide wire is pointed in the direction of the abducted thumb. So aim it in the trajectory of the thumb. It doesn't have to go all the way to the proximal cortex. Stop 3/4 of the way, and that is your length. Measure.
Thank you. Okay. Mid abduction. How much abduction?
Mid abduction. Slightly.
now from morning you are fixing the fracture and some treatment you are doing. Now we cover the rehabilitation part. Understand? The rehabilitation always an integral part to find successful hand, successful hand function. Okay. Our goal is to restore pain-free functional hand. If we fix nicely, we stitch nicely, we have a good scar, but if we have not used our hand, that is useless. Everything gone bad. So that is the only reason that behind that we have to rehabilitate after whatever injury or surgery we have to rehabilitate to get the fully functional hand. That is our goal. When a person comes to us, we have to find out the hand should be fully functional to give him the care. And it is always a team approach. All team members should voice about the rehabilitation protocol. That's why this is there. Rehabilitation has following steps, some 5-6 steps. Today I will only some 5-6 moments I will tell you, or steps I will tell you. First is communication. Communication means among the persons who are involved in rehabilitation, like plastic surgeon, orthopedicians, and PMI specialist, or hand therapist, or rehabilitation nurse also. They all should know what you are doing. What you are doing, everybody should know to give him a better functional hand. Then next is the patient education. Patient education must, because whatever if you will not educate the patient, if you advise do some exercise or prevent this, he will not do, then he will come on with stiff hand, or joint will be stiff, muscle will not act properly. Like importance of a compliance with home exercise program. It should be properly done. Protecting a surgical site, managing the expectation, how much recovery time he will take, signs of complication, because patient should know what is the complication, otherwise he will not come back to you. It will complicated and function will reduce. First is the communication, second is the patient education, third is the edema management. Edema management, whichever any contusion or any complex injury or any fracture, any surgery, you find there is a edema in the hand. If edema persists, then it will give a bad functional hand. Otherwise, hand will stiff, it will not give a good result. The first thing is early management, because rehabilitation starts with when patients comes to you. You start with from that day onwards. First, you reduce the edema. We know all elevate compression and safe mobilization. Sometimes ice also we applied, and in our department we are giving electrotherapy and some soft tissue massage. It helps to reduce the edema. Next step is mobilization. Mobilization, this is the early protected mobilization. Is a important regimen. Early protected, imagine the word, early protected mobilization. You have to protect the repair if anything done. Suppose this is a single fracture, like metacarpal fracture or tarsal fracture, and it is closed fracture, it is okay for you. But when there is a injured hand comes to you, it injured bone along with tendon, nerve, vessels, everything. So we have to take all the account. Understand? That's why early protected mobilization, protect the repair part and mobilize the parts. That is the main key in the rehabilitation. Otherwise, hand will get stiff. The active movement, how it helps? It maximizes tendon glide. Hand is prone for adhesion. Maximize tendon glide, prevent adhesion, edema management, preserve joint movement, reduce complications, and ultimate functions. It helps early protected mobilization. As early as possible, we will mobilize the hand after surgery or after conservative management also.
we have to protect the tissue and then mobilize. We'll go one by one in mobilization first. When there is a fracture, what we'll see first? Fracture, our lookout, fracture is stable or not, which type of a fracture, and what are the deforming force to the fracture. If fracture has we have accordingly type and stability and deforming force, there is you can manage non-operative or surgical. If non-operative management, you have to give some rest. But when you are giving rest, the uninjured structure around the fracture, you have to mobilize. You have to mobilize all, to keeping the injured part in immobilized state. That is the goal. If surgery indicated, then fix it in solid way, in fixed properly, you can mobilize early. Along with, there is a solid fixation. That is in the case of a fracture. If there is a tendon repairs, if need tendon repairs, then early protected motion is important. What happens if tendon, either we have a repair flexor tendon or extension tendon. If there is a flexor tendon injury and you repair it, always prevent by the dorsiflexion stop. Means dorsiflexion stop, like this. You see this figure, like this. Understand? You stop it, don't allow extension of the finger. And keeping in that, mobilize the finger. In extension tendon injury, we have a short arc motion regimen, where we only allowed some form of like 10 to 15 degree of a flexion, limited flexion, but we can allow extension. Then, if small joint replacement is there, any small joint replacement, in that time, you have to mobilize the joint as early and protect only that portion of the joint for 4 to 6 weeks. After mobilization, next step is splinting. It is a major step in a hand rehabilitation. Splinting is an important thing in rehabilitation because it immobilizes or mobilizes the injured hand, it protects the repaired structure, maintains soft tissue length, and prevents development of a contracture. We can use thermoplastic, custom-made splints, or sometimes in early stage, cast also you can use as a splinting. Immobilization. In immobilization, you see there is a fracture in the base of the proximal phalanx. So there is a two force. One is flexion, one is extension. Flexion means intrinsic muscles are acting as a flexion. If you will leave untreated, that will deformity will more aggravate. So in that case, we have to splint in the flexion position to align it to neutralize the extension portion. If see there is a mallet finger, we have to give a splint which keep the finger in the distal DIP joint in a fully extended form and mobilize the proximal phalanx. This is same mobilization with splint. Protected mobilization. As per requirement, you have to give a splint, protect the motion and use other part. Another is the assisted mobilization. Assisted mobilization means what happens here, you give the splint. Here you see this figure. This is known as Kaifunger flint, where when you flex the finger. When it extends, it helps in the extension. So it added the effect of a extensor tendon. It adds the effect. Like that, this is also some rubber bands are there. When you flex, and that rubber bands will extend it. So it helps the mobilization. Our main aim is the tendon should glide or slide in between their groups properly. Positioning. The splint also helps in positioning. Suppose there is a nerve injury, ulnar clawing. Ulnar clawing, what happens? There is a metacarpophalangeal hypoextended, other things have flexions, then in that case, we can maintain the position by giving the ulnar splint. And if there is a full clawing, we have a knuckle bender splint. We can use that knuckle bender splint, which keeps in the position. Static progressive, sometimes there is a deformity persisting in the finger. In that case, what happens? We give the static splint, then every 5 to 7 days, we change that splint, or we hit that splint and change the angle, and gradually we correct the deformity. That is the static deformity correction. Sometimes we can use also POP cast. After giving POP cast, remove, again stretch, give him POP, it will straighten the deformity. There is a finger flexion deformity, gradual CL casting also helps in the extension. In that case also, you can use fit splint. Fit splints, that splint, you hit it, again you can remodel it. Hit it, again remodel. You can use that. Then after splinting, next is the exercises. What are the exercises we have to advise the patient? First is the passive movement. Passive movement is the gentle and you should not apply any force. It is typically a precursor of exercise. First, you have to advise the patient. Passive means the therapist or you have to do the movement to keep the range of movement intact. You have to tell the patient you have to do. Patient will not do anything. Understand? That is the passive exercise. Followed by that, active movement. Active movement means patient will do. Patient will, his muscle will contract and he will do that exercise. That is the active movement. Here, there is some steps of movement in flexor group. There is, first you have to keeping straight, then gradually, this is the sliding methods of the tendon education in the hand. It prevents the adhesion of the tendons. Differential tendon glide. What I show in figure, this is a differential tendon glide. First is you keep tendon in extension, then gradually IP joint flexion, then gradually fixed, then keeping a tabletop position, then fixed. That is the differential tendon glide. And always in hand, remember, give minimal dressing. Don't give bulky dressing. Bulky dressing also prevents the active mobility. So don't apply any bulky dressing. Always use small and minimal dressing. After active mobilization, go for the assisted movement. When you achieve, there is a active mobilization in the fingers, all these things, then next schedule is assisted movement. Give him some form of splint and assist whichever muscles you require to assist as per assessment of yours. Then after assisted movement, go for the resisted movement. Resisted movement always helps in strengthening of the muscles. When everything is settled down, suturing over, means you know that all things now complete, then you resisted movement, you advise him resisted movement to increase the power of the muscles. Okay. And this is all about what are the steps in hand rehabilitation. The phases of rehabilitation, roughly we categorize in 3 phases. But it has a superimpose of each other. We can plan as per case-based. It is somewhat like a strict follow this. You can see case-based as per your need of the patient. One is immobilization phase, 0 to 3 weeks. We keep splinting or casting, edema control, pain management. But you always try to mobilize. Whenever you see that there is not injured much or not tear the muscle more. Early mobilization phase, 3 to 6 weeks, where you give gentle range of motion exercise and scar management. Scar management is crucial in hand rehabilitation. In other long, like other long leg or thigh, then in hand, scar management is more crucial. Strengthening phase, 6 to 12 weeks, where we prescribe resistive exercise. We have to find out the grip, pinch strength, functional attacks, and resistance exercises. and always teach the patient about the complication. Whenever he faces complication like joint stiffness, tendon adhesion, chronic pain, CIPS syndrome, or wound healing problem, then he has to immediately come back and contact to your persons, whoever concerned. Then after everything over, we have to send the patient in ADL activity. ADL means activity of a daily living. What he can do in that hand. We give them resistance, we gain back their power, we have given their range of movement, everything he become, then we try to make him a normal hand. How we'll do? We have some modalities with us. He has to practice daily here. Holding either grabs, pinch, hook. Hand has three functions. One is grabs, one is hook, one is pinch. This is the main function of the hand. You have to think. So everything we have to see he is doing or not. Then after doing that, we have to give them the simulation. Like we have some in our department, occupational therapy department. Occupational therapy deals with mostly in this therapeutic using. The occupational therapy department, there is a like simulation like there's a door closure, door, everything is there, zipper, all these things he will do there. After doing that, we confirm he can do their ADL activity. Then we will advise the exercise and we'll send back to the patient home, exercise program and go back. Suppose everything done, still you cannot achieve the required function of that hand. Then what will do? Patient has to do the work. No? We cannot live like that. Then we have to plan, you have to do some external modification, we have to some assistive device to make their functions. See like this. This person, he cannot hold that pen to write there. Then how can he go, he's a clerk, how can he write in their office after injured? Then we have to design a pen like this. Cylindrical gaps is there. So he can hold that and he can write and he can go back to their job. That is the all steps of rehab. See, he can nicely writing in that, holding that finger. We have universal cough, he can brush it. We have, if there is a, I am not telling that one bone fracture, there is a hand injury completely, he cannot functional. Whatever methods you apply, then we have to rehabilitate in another way. Main conclusion is there should be a good communication with all your team members. Patient education should be there. A collaborative team effect should be there. In between any complication, we have to think about the surgical persons, touch with the other persons. Early mobilization, splinting, and exercise. This is the main stem of our rehabilitation system in a hand. Thank you. And regarding rehabilitation, if you have any doubt, you can ask. Or anything, you can, any suggestion also you can tell. No problem. It will be better for patient. Whatever we are doing for patient. We ultimately, we want the good functional hand.
How do you deal with CRPS? That is a very common problem in hand.
When CIPS patient is very resistant to all the treatments, first we have to counsel very patient. We sit with many times we have given for the block ganglion block. We are giving a ganglion block, and it result is fantastic. After ganglion block, again continuous therapy. Patient, but CIPS we tried here 4 or 5 cases ganglion block that work like anything.
How frequent is it?
CIPS we are getting hardly means 6 months. Frequently we are not getting because patient will not come into us. Once. Once blocked, one person around 59 years, one male was there. They have some other cause, means injury, some distal radius, police fracture, plaster, then come back. He has a lot of swelling, like CIPS features. So we tried all the modalities, everything, even medicines. Always come to OPD and pain, then we go for the ganglion block, and anyhow it subsides and go back. Still a ganglion.
With alcohol?
No, xylocaine and.
Thank you. I think any doubts or anything? So, small token of appreciation to recognize our volunteers.
What can be done differently? So it's a learning process for us also. So that is why the feedback. You don't need to tell us, sir, very good, very brilliant. So some critical feedback, constructive criticism, of course, is always.
Dr. Arus.
Earlier, after this also. So thank you all the delegates and the faculty who have come all the way to teach us and share their knowledge. So, and thank you, sir, for conducting this event. It was beneficial for everyone. And thank you to all the team, the resident faculty and the staff of the plastic surgery, burns and plastic surgery team who have effortlessly and tirelessly have done this job. I have mentioned earlier also. Now I want to say a special thank you to KLS Martin team, though they are not inside this seminar room. So I think they have left. One person has left, and the other Kalyan is there. Thank you, sir. So special thank you. Kalyanji, thank you for this beautiful session. I hope we'll have such sessions earlier again. Thank you all. And sir, I want to give the mic to you for the last few words if you want to say.
Anyway, this was a think of, as I have already told that why we have planned it, because many times in our times also when we are doing these cases, we don't know how to fix, only fix by giving a KOR. So nowadays everything has come out and KLS come with a very beautiful things. So that, and initially first you people are seeing these cases in institutes. So it should be known by everybody what should be given at what time. And I hope after this the treatment will be different, because if we will plan, then accordingly things will happen. KOR gone, all things has now come, so we have to think in that way also. Thank you for coming from a long distance, those who have come, and to all the residents, and for attending this one. Next one we will try to do better. There may be some lacunas for this, from us apologize, but because it has been done very fast in 1 or 2.5 months, I think. But I think I am really thankful to Ravi sir and Tahir sir, because it was the master brain of Ravi, because we have what to do, what not to do, and sir has given in that these things should include, so that it will help. So big clap to for both the faculties. We can have a last photo there, and we can leave. And we have all those plastic surgeons coming from outside, they can have a visit of a burn center of our, which has been made just behind that one. It's a burn center which is made from the CSR fund. So you can also see those who have any interest in burns, so they can have that visit of that center. Or anything anybody wants to tell, you can also tell. If anybody wants to tell any feedback, if you have given feedback. Huh? Madhvi, want to say anything?
Having no idea what to do at that particular time is feeling very helpless. So having some idea of how to manage them will help me improve my patient outcome better. So I just wanted that if we could have more of these workshops and more, especially with respect to tendon injuries, especially extensor and rehabilitation, early mobilization, how to prevent adhesions and all of that, that would also be a good thing.
So basically, I would encourage all of you who are interested in hand surgery to become members of the ISSH.
I am.
And you are. So you are aware of these basic hand courses. They are all over the country. So every region we have at least 3 or 4 basic hand courses, which is a 2-day event, not 1 day. It covers both soft tissue and here. So along with that, we are now, the next plan is to have an intermediate level hand surgery course. So basically, plus there are a lot of short-term fellowships. So I understand as a working professional, it will not be possible for you to take too much time. So if for a weekend you want to visit any high volume center in any part of the country close to your place of work, we can arrange that. We have a very good understanding among all our colleagues. So if you want to come and say 2 days, maybe at a weekend in a high volume center, even 10 cases you assist and go, you will go back very confident. So that offer stands open to all of you. Just become ISS members. It's a very vibrant society. I'm not saying it, I'm canvassing. I have no conflict of interest. I'm not official of, I don't have any official post or anything, but simply participating, I have found out. And next year we are having the conference in Kolkata, so again I'll extend a welcome to all of you. Please come. It will be a very interesting conference and hopefully very useful to all of you. Okay, thank you.
Abhishek, Arus, anything? Because you are also busy in diabetic foot and all.
Yes, sir. I actually really looking forward to this. Hand fractures is something that in our institute orthopedicians do more. So we lack the exposure and even the basic knowledge about some of the things we learned today, the intramedullary screw and other techniques. So I think it was a very well organized workshop and especially beneficial for all the plastic surgeons who are practicing on their own without any guidance from their orthopedic colleagues. When you're a standalone practitioner, you don't have the support of orthopedicians sometimes. So sir, this has been really helpful for me and I'll be going back and implementing what I've learned here. Thank you so much.
Sir, benefited a lot from this workshop.
About your department, you have started
Sir, I started my department alone doing onco reconstruction and burn contracture mostly. We started vehicle cases 6 months ago, and filaria is more prevalent and nervousness.
Now we can start hand.
Yes, sir. I do along with the orthopedic cancer.
Anybody wants to say anything? Otherwise we'll wrap up and we'll have a final photograph. From our institute, anyone wants to come? Sorry? Anything? Sir is there, so definitely. Surya? Surya also.
Hello.
So this hand workshop and fracture fixation workshop has been very educative and informative for all of us. But as Madam rightly said, we look forward to many more workshops regarding tendon repair and rehabilitation protocols, all those also. But we thank both Bhubaneswar sir and Tarik sir for taking time and coming to us, especially from their busy schedule. And we hope we'll have more and more interactive sessions and if possible operative sessions as well in the near future. Thank you, sir. And good
So we'll have a final photo there with all of us.
Ready, sir?